Good morning, Kolanda.
Good morning.
Yeah, I think it's the right time to start the class. So I hand it over to you for conduction of this most important session of this weekend classes, that the clinical discussion on the renal cell carcinoma and subsequently its management. Handing over to Dr. Sarkar for continuation of the class. It's just 10 o'clock. You can start the class today.
Good morning, sir. Good morning, sir.
Good morning, good morning, good morning, everybody. Devang, welcome. Students are all present.
Yes.
Students are all present. Hello. Can you hear us? Can you hear me?
Yes, sir. Dansagar is here.
So all three of you are present for the first case and all.
Yes. The first case, two cases will be presented by Dr. Devango Sarma. Dr. Sashank Bolivar is unable to. He has sent his presentation very nicely, and Dr. Devango will present the first, will conduct the first two case discussions. The students involved are Dr. I think, are you all here? Dr. Jitendra Agarwal, Dr. Kishore Tonge, and Kishore Tonge, and for the second case, Vishal Kashyap and Dr. Arnab Maiti. So over to you, Dr. Bango.
Yes, sir. So first, I will be presenting a case of small renal mass. Is it visible? Right. Is it visible?
Not yet.
Yeah. So students are here.
The first slide is visible. First slide is visible.
Fine, sir. So the students are also ready, Jitendra and yeah. So shall I start, sir?
Please start. Please start. Your presentation is visible.
So the case is a 49 years old Muslim male who complained of pain abdomen since last month. This is his chief complaint, right? Then comes to the history of present illness. It was a pain. A patient developed a pain abdomen which is insidious in onset, dull, aching in nature, and it is continuous. There is no radiation. It is relieved by medication. There is no history of hematuria, lump, swelling in the flank, no fever. There is no colicky pain. There is no history of burning micturition, fever. There is no history of diabetes mellitus or hypertension. Never had such complaint in past. There is no history of any surgical intervention in past. There is no history of any drug allergy or anticoagulant. Patient is non-alcoholic, non-veg, and doesn't smoke. Bowel and bladder habits are normal. Married for 25 years. 6 children are there. There is no major family history. So in summary, there is a 49 years old male with dull aching pain in abdomen since last 4 months without any comorbidity. So the patient, usually this type of patient comes to us with directly with all the investigations. So I am putting it in that way. So on general examination, everything is normal. Per abdominal examination, there is no positive finding. Systemic examination, normal. DRE is also normal. Back and spine is also normal. Patient came with all this investigation up to ultrasound to us. So in the routine urine examination, everything is normal. Urine culture is sterile. All investigations are within normal limit. These are all investigations the patient came to us. They came with an ultrasound KUB, was referred to us, which showed, there is a well-defined hyperechoic lesion in the hyperechoic to mixed echogenic lesion of approximately 4 centimeter with internal vascularity in the lower pole of the kidney. And the right kidney is normal in size and shape. Everything is normal. Corticomedullary differentiation is maintained. Now our case starts. So what are the differential diagnoses of the masses, small renal masses with mixed echogenic on ultrasound?
Sir, first is renal cell carcinoma, sir. Second will be renal abscess, sir, mixed echogenicity. And third will be, sir, chronic pyelonephritis such as xanthogranulomatous pyelonephritis, sir.
Right. So how we are going to differentiate it radiologically? Some indications in ultrasound by which we can differentiate them?
Sir, renal abscess, there is a rim sign that is well demarcated in renal abscess, sir, and hypoechoic area in the rim sign, sir. That and debris within it that indicates renal abscess, whereas
anybody? Yeah. So we have 3 differential diagnoses of mixed echogenic renal masses, the most common ones. One is the malignant mass. So in malignant mass, it is always we see a central vascularity. You have not mentioned the Doppler. You have a central vascularity always. In abscess, you have said, yes, the rim sign is there, but you don't have vascularity. You will have vascularity, increased vascularity in the periphery, right? Then
yes.
Chronic pyelonephritis, the normal thing that we get is infarction, right? It is usually a triangular lesion with apex in the central part, and there is no vascularity. So these are the 3 most common masses that we get encountered in ultrasound. What will be the next imaging modality that you want to do?
Sir, as a patient is for greater than 40 years and having renal mass on ultrasound, I would like to do contrast enhanced CT scan with abdomen pelvis, with triple phase contrast CT scan with abdomen pelvis, sir.
What do you mean by a triple phase CT scan?
Sir, it is involving arterial phase, venous phase, and post contrast, sir, voiding post contrast film with pre-contrast HU units, sir.
Why we need a triple phase CT scan or triphasic CT scan in case of a renal mass?
Sir, to see for the enhancement after the contrast and washout after the contrast execution, sir.
Yeah, what is the role of an
And
excretory film?
Sir, to excretory film, to see for the bilateral kidneys are functioning or not, or opposite side of kidney is functioning or well or not, sir. That's why excretory. And the pelvic LSA system is involved or not, that is also
important, right?
Important,
so one thing that you haven't mentioned is the angiographic phase. That is very
along
much
with
required
the
in this case, right?
Yeah.
Okay, very good. Yes. So this is a CTI view. I don't have the angiographic film. Ideally, I should have an angiographic film in this case. This is a non-contrast film on the left side. We have a corticomedullary phase on the right side. I don't have all the films as it's not possible here. So this is a nephrogenic phase and this is a coronal section. So what does it say? It's a heterodense lesion that is measuring 3.7 to around 4 centimeter mass in the lower pole of the left kidney with exophytic component. there is intense enhancement of corticomedullary phase, and there is early washout of nephrogenic phase, and there is peripheral non-enhancing rim. There is no extension to left adrenal gland, and there is no adjacent pararenal facial thickening is noted. So this is what we got in CT IVU. Now, will you modify the diagnosis? What is your diagnosis right now, as we have all the investigations right now? What is the diagnosis?
Sir, it's a renal cell carcinoma, sir.
Yeah, renal cell carcinoma. Okay, it's a malignant renal mass, right?
Malignant, yes, sir, malignant.
Whether it is malignant or benign, how will you say from the history as well as the films that you, as well as the investigations that you have?
Sir, a malignant mass on history wise, sir, patient is mostly of elderly, sir, greater than 50 years, presented with short duration of symptoms, and most of the symptoms, most of the patients are asymptomatic, greater than 60%, sir, and when the patient came with symptoms, it is advanced disease, sir. And this patient, as a pain of abdominal pain is since 4 months. This is of not long duration as such, within 4 months, and on imaging, the mass is well enhancing and heterogeneous in ecotexture. That's why. And
See,
in benign, sir, the mass is not enhanced. Enhancement is not there.
yeah.
নিয়ে যেতে হবে ওটা আমার সামনে থাকুক তাহলে ভুলে যাবো আমি
The thing is that from the history, the patient is an elderly, almost 50 years, right? Then
Yes, sir.
onset is insidious. There is a vague complaint. Patient is male. Then we in ultrasound we have a lesion which is, you have to go step by step. In ultrasound you have a lesion which has got central vascularity. Then in CT scan there are few things that is very important. There is enhancement of corticomedullary phase. Can I ask you what amount of enhancement is required to label it as a malignant from a non-contrast one?
Greater than 15 to 20 Hounsfield per unit, sir.
Yeah, it has to be 35, then we are very much sure. More than 35, we are very much sure, right? And the most
Yes.
important thing, the most important feature in a CT scan of saying that the mass is malignant is early washout on nephrogenic phase. What do you mean by early washout on nephrogenic phase? And what is the reason of early washout in a malignant mass?
Sir, the contrast, when we give it, it is in the tubules that is seen on the contrast CT, sir. In renal malignant mass, the tubules are destroyed. That's why it is excreted out as compared to the normal parenchymal tubules, sir.
Actually, the reason of early washout is that in a renal mass there are many AV malformations, right? When there are
Yes.
many AV malformations, that causes early washout of the contrast. So
আমাদের তো
this is
বোধহয়
the reason for early
একটা নাকি
washout in
দেখে নাও
nephrogenic
তো
phase
টাইমটা
in case of a malignant mass, and this is one of the main features in CT scan by
তাহলে
which
তাই
you can say it's a malignant mass along with enhancement, right?
Yes.
Hello.
Do you think you need a biopsy in this case?
No, sir.
Why? If no, why? And if yes, why?
Sir,
Ruma, please mute everyone excepting who.
Yeah, I have muted everyone. Dr. Sharma, please unmute yourself.
Yeah. When we do you need a biopsy in this case?
no, sir.
Why no? And in which cases you will do a biopsy?
Sir, biopsy is indicated in only the patient is not not fit for surgery, or a frail patient in which the bilateral kidneys are involved, whether is other side kidneys not is also involved, and whether we are in doubt whether it is abscess, infectious renal mass, or to differentiate from metastasis or lymphoma. In these cases, we need renal biopsy, sir. Otherwise, when we suspected exactly a renal cell carcinoma and in a patient is surgically fit, then we have we not need to go for biopsy, sir, renal biopsy.
Why not biopsy? What will be the disadvantage if we do biopsy in this case?
Sir, there are chances of seedling of malignant cells, sir, when we do percutaneous biopsy, sir.
Right.
This is one chance, and post biopsy complications are there. That's why we can directly go for surgical management, sir.
Yeah. So if we do a biopsy, if it turns malignant, the chances of needle track seedling is high. Not that high, but it's high. Why to take risk? Even if it's not malignant and it comes out to be so there is no need of biopsy actually in this type of cases. Yes, we need biopsy if we are planning or the patient is not consenting for any nephron sparing surgery. If we are going for an active surveillance or a thermoablative therapy, then we need a biopsy, right? So there is no need of biopsy in this case. Do you think any other investigation is required?
Sir, in this case, I would like to do X-ray chest and left liver function test, sir.
Of course, liver function test is already presented to you. It's normal.
X-ray chest.
Any other imaging modality that you want to do?
X-ray chest, sir.
Why not a CECT thorax?
Sir, patient is not having any pulmonary symptoms, sir. And I like to go with X-ray chest. If there is any doubtful lesion or patient is symptomatic, then I go for CT, sir, HRCT thorax.
Yes.
Otherwise, not necessary, sir.
Actually, few years ago, chest X-ray was sufficient for this. But nowadays, in guidelines, they have included CECT thorax if possible. If the financial thing is good, if everything is available to us, CECT thorax is always advisable in case of malignant renal mass. The moderators and other teachers, if they want to say anything regarding this.
I agree with Dr. Sarma that recent guidelines all suggest the use of a CT scan, and if the patient can afford it, even a non-contrast CT thorax, the MDCT is also, you don't even need a contrast CT if already a contrast CT of the kidneys have been done.
Thank you. So what is a final diagnosis right now? Who others are there in the student? Only Kishore is there. Anyone else? No. Okay.
Yes,
what is the final diagnosis?
Sir, it is small renal cell carcinoma with stage, sir, T1 N0 MX, sir.
Okay. MX, it's already been made.
Already, sir, T1 N0 M0.
What will be the plan of management in this case?
Just a moment, Dr. Sarma. I think Dr. Jitendra Agarwal is.
Yes, sir.
Yeah. So why don't you make yourself visible and take part in the discussions?
Sir,
Okay. Jitendra, you are there, right?
Yes, sir. I am here, sir.
Okay, you can show your video. You are not visible, right? Yes. Jitendra, I can see you right now. Okay. So now what will be the plan of management? You are following the case, right, Jitendra?
Yes, sir. Yes, sir. Yes, sir.
What will be the plan of management right now? Yeah, everyone take part. That will be good.
Yes. Sir, plan of management, sir, in this case, should, sir, this is a small renal mass, T1 is, sir. So, sir, we can think of doing partial nephrectomy in these patients, sir. And
Yeah, you are
nephron-sparing
planning for a
surgery.
partial nephrectomy. Okay, fine. Very good.
Yes.
Kishore, anything else you want to add?
Sir, I will also go for nephron sparing surgery in this patient, sir. But before that, I will consult the patient and put the two surgical management, nephron sparing surgery with approach of laparoscopic or open and radical nephrectomy, sir. As a patient of greater than 50 years, if he is willing for regular follow-up, then I will suggest him nephron sparing surgery, or otherwise he can go for a radical nephrectomy directly, sir.
Okay. What are the indications of nephron sparing surgery? One thing that I want to say, there is little bit difference between nephron sparing surgery. Nephron sparing surgery doesn't mean that it's partial nephrectomy. But nephron sparing surgery includes three things. It includes two things. You have partial nephrectomy as well as the focal therapies, right? So in exam, I think it's better to give the answer in nephron sparing surgery. Then you can invite other answers also, I think. So what are the indications of nephron sparing surgery?
Indication for nephron-sparing surgery is if there is total renal volume of the patient is decreased, there is deranged renal function of the patient. If patient has solitary kidney, and if there are multiple tumors, patient is having multiple tumors, so bilateral tumors, patient is having bilateral renal tumors. In that case, we should prefer nephron sparing surgery.
Yes. Nowadays, one more indication is there, not nowadays, and the thing that has not been included in Campbell. Any small renal mass which is less than 4 centimeter in mass and patient is willing for a partial nephrectomy, that is an indication of nephron sparing surgery. And rest you have said all, right? Now, what are the other options of in nephron sparing surgery? In nephron sparing surgeries, what are the other options?
In nephron sparing surgery, sir, other options, there is cryoablation, sir, and we can do radio frequency ablation, sir, and we can, if the tumor mass is small and if patient is having VHL syndrome, sir, in that case, we can wait and we can do active surveillance, sir. If there is up to 3 centimeters, we can wait and watch. And if there is sudden increase in tumor mass, and if there is more than if tumor mass is more than 3 centimeters, then we can proceed for surgery, sir.
So we are going one by one. Active surveillance. When we will do active surveillance? One by one.
Sir, yes, sir. Sir, we will do active surveillance in if there is small renal mass, and like if patient is having VHL syndrome, and patient is having multiple tumor bilaterally and they are small size, and like patient is having tuberous sclerosis, known case of tuberous, then if tumor size is less than 3 centimeters, so then we can wait. If patient is willing, sir, if patient is willing to wait and he is not willing to get operated, then we can do, sir. And uh, after a certain limit of size of tumor, we can go for surgery, sir. And if sir, patient is not fit for surgery and the patient is not willing for surgery, sir, in that case we can do active surveillance.
Active surveillance, one of the most important thing that is required, which is not of course surgically related. Patient has to be literate. He must give consent of regular checkups. Many of our patients, they lost to follow up. These type of patients, you cannot afford a active surveillance, right? So he has to be literate and he has to know what is the importance of active surveillance and what is happening to him, right? Then what are the indications of percutaneous thermoablation, Kishore?
Sir, any mass that is less than 4 centimeter and patient is not willing for focal therapy and willing to do for regular follow-up, that is the indication of percutaneous thermoablation, sir.
Okay. Now, do we need to do a radical nephrectomy in small renal masses sometimes? If yes, what are the situations?
Yes, sir. In some small renal masses, we have to do radical nephrectomy. Previously, it was suggested that when the tumor mass is near to the collecting system or the hilar structure, that is vascular structure, then we have to do radical nephrectomy. But nowadays, the trend is going more towards the partial nephrectomy. When the tumor mass is also near to the collecting system, we can do partial nephrectomy in that case also. But in these two cases, one can see for radical nephrectomy when the tumor mass is near to the or approaching the collecting system and the hilar structures, sir.
Yes. Now, the thing is that in radical nephrectomy is nowadays only indicated in small renal masses. In those cases, those renal tumors, hilar renal tumors, which have invaded the vascular system. Even nowadays, those can be resected. The only indication now remains is if patient is not willing. In an elderly patient who is not willing with a normal kidney on the opposite side, we can go for radical nephrectomy if the patient doesn't want a partial nephrectomy or not giving a consent on partial nephrectomy, right? Now we need to do counseling for partial nephrectomy. We have to say to the patient that we are going for partial nephrectomy. These are the things that may happen. What are the considerations? What are the things that we need to keep in mind while counseling?
Mainly, sir, two factors post radical nephrectomy. First is chronic kidney disease, sir, and post-op
It is partial
complications of.
nephrectomy. It is partial nephrectomy.
Sorry, sir. Post-op complications and post-op regular follow-up, sir. Intra-op and post-op special complications such as, sir, urinary leak,
Yeah.
hemorrhage.
We'll come to complications later on. Just enumerate the points, right?
Sir,
So we need to.
complications post-op.
Yeah, continue, Kishore.
And post-op follow-up is required, and if the recurrence is there, and the patient may land up in radical nephrectomy or other the ablative therapies, sir, for recurrence.
Yeah, you have to say regarding complications, but one of the most important point that you need to counsel before entering the OT is that patient may need a completion radical nephrectomy in case of any untoward event that may occur during the operation or during the OT. So that is one of the most important thing that you need to explain. Yes, you have, of course, you have to say regarding the complications, the chances of recurrence, and may need a radical nephrectomy or other focal therapies later on, or the possibility of positive margins, right?
Yes.
Anyone can tell what are the steps of open partial nephrectomy. I am not saying I will not be discussing the laparoscopic one, the partial nephrectomy, the open one, whatever way you do in your institute, right?
Sir, we do in little positions, sir, patient, and we dissect, sir.
Concise one. Just tell me the steps, the salient points, the position, the incision, the main steps.
Yes, sir. So flank incision we will give, sir, and main steps, sir. We after opening Girota fascia, sir, and we will reach up to hilum, sir. We will dissect renal vein and renal artery, and we will confirm that how many renal arteries are there, and after properly dissecting renal artery and veins, sir, we will see location. We will check location of the tumor where it is actually, and after that we can sir completely occlude hilum, sir, or may we can partially the segmental artery which is specifically supplying renal tissue which having tumor, sir. We can just occlude that artery, and after that, sir, we will see
what you do in your institute, whether you clamp the artery only or you do an en bloc clamping.
Sir, we do, sir, both approaches, sir. Sometimes we occlude both renal artery and veins, sir. But nowadays we are just occluding only arteries, sir. And,
Are you finding
after,
any advantage over only artery, advantage of only artery clamping over en bloc clamping?
Sir, personally, sir, I cannot compare. I cannot just say if there is any difference, but it it's theoretically it looks better to
Theoretically.
not to. Yes, sir. It is better not to touch a vein, because if you touch vein, maybe there are chances of some injury to vein, sir. So it is better not to touch that.
The congestion may happen.
Congestion, yes, sir. Congestion may happen, sir.
Okay.
That's right. You're right,
Okay,
sir.
proceed. Let's take.
Yes, sir. And second, sir, we will see after partially or completely, if we are completely occluding renal arteries, then there is no issue. Then we can directly proceed and we can just mark tumor and a good margin. And after that, we can do resection of the tumor, and we will check, sir, if there is any tissue left, or if there is improper resection. And after completing that, sir, we just with using PDS or proline 40, we just tie all the vessels, sir, and after that we just close the calicial system, and after that, sir, we completely close this defect, and then we declamp the artery, and if there is any bleeding still happening, and then we control that. And if we are doing, sir, partial renal artery, if segmental artery we are blocking, then after a few seconds we will see there is no blood is not reach. Rest of the kidney will be perfused, sir. Only we will check if the segment which is having renal tumor is still perfused or not. If it is not perfusing, then good. Then we will further proceed for partial nephrectomy. The rest of the steps are same, sir.
Okay.
And
do you think cooling is required?
Sir, yes, sir. In our institute, we use, sir, ice packs, sir. And if we feel like, sir, in one or two cases in our institute, we didn't use ice pack because that was done in like 10 or 15 minutes or something. So if we, I think, sir, if we are completing our surgery in 25 to 30 minutes, then maybe we can just proceed without ice packs. But yeah, most of the cases we are using ice packs, sir. So
Okay.
we use.
What does the literature says?
Sir, if it is taking more than 25 to 30 minutes, sir, then there are chances of natural loss. So, yes, sir. So in that case, ice packs are required, sir. And after completing, sir, if we can use pistol and all these things too, and we use, sir, this just to pistol and all we use, sir. So to completely achieve hemostasis, sir.
Okay. If the facilities are available, do you think frozen section is required?
Sir, that is frozen section, sir. Actually, if we are enucleating tumor, sir, yes, in that condition, frozen section is done. But sir,
If you
in
are
most
not
of the cases,
enucleating the tumor, if you
sir,
are
no,
not,
sir, then frozen sections, sir, to be on safer side, so we can send frozen section, but sir, there is no support for this part, because it will unnecessary, increase the time of surgery.
the warm ischemia time will increase, right?
Yes, sir. Yes.
Okay, good.
Dipango,
Pardon, sir?
yes, there is a question from Dr. Ashu. Is clamping always necessary? And what are the different ways, instruments, and other ways of clamping? And to this, I will add a third question: is what to Dr. Jitendra?
Yes.
Is what are the specific advantages of open partial nephrectomy over laparoscopic partial nephrectomy?
Yeah.
So first answer Dr. Ashu's questions. Is clamping always necessary? And what are the techniques of with which you do a clamping?
Sir, to whom, sir? To
Jitendra.
Sir,
Jitendra.
Thank you, sir. Sir, if tumor is more superficial, sir, on CT finding, and if we are palpating and we feel tumor is, sir, am I audible, sir? Hello?
Yes, carry
Hello?
on.
Sir. If tumor is superficial, sir, if it is not not much endophytic, sir, then it is more exophytic. Then we can, sir, do without. We can try, sir. In our institute, it is never tried, sir, without clamping. Yes, but in theoretically, I think that, sir, if it is more superficial, then we can try for without clamping, sir. And if tumor is more endophytic, sir, then I think we should go for clamping artery first, and after that for partial nephrectomy.
Yeah, what are the different types of hilar clamping, as Anshuman asked?
Sir, hilar clamping, sir, sir, we can completely occlude the renal artery, sir. We
You
can
have seen both the en bloc one and the artery only clamping, and other ways.
artery. Yes, sir. En bloc, sir, artery only, and in artery only, sir, only segmental artery, which is
That is
supplying
called highly
that.
selective or selective segmental artery clamping.
Yes, yes, sir. Yes, sir. Yes, sir. That, yes, sir.
And another one is there, parenchymal clamping.
Okay, sir.
In parenchymal clamping, we do it with hand. We clamp the,
Yes,
if
sir.
the tumor is a peripherally located tumor or it's a polar tumor, we can clamp it with the hand. With our both fingers in between, we clamp it and we remove the tumor. It is possible. And there is another instrument that I haven't seen ever, but yesterday I presented, that is parenchymal clamp. Kidney parenchymal clamp can be used, right?
Okay, sir. Okay.
Over to next question. The next question: what are the advantages of open over laparoscopic?
Sir, in open, in open surgery, total time of doing from clamping to excising tumor, and after that completing partial nephrectomy is less in compared to laparoscopy, sir. In first, sir. Second, sir, in partial nephrectomy, there are more chances of complete removal of the tumor. But in laparoscopy, sir, there are chances that we will just end up in inequilibrating tumor, and yeah, there are chances of positive margins.
So really, how do you prevent positive margins at say at an open partial nephrectomy?
Sir, mostly, sir, 5 mm margin if we take from the tumor, and if on clinical judgment, sir, if we find any if we see, sir, still there is tissue which is left on kidney, which looks like it is tumor, it's hard, and then we can, sir, further excise that tissue, sir, in open, sir. But in lab, sir, we cannot have that tactile sensation, and we can just end up with positive margins.
Yes, the tactile sensation is one of the important thing that is present in open, and we don't get it in laparoscopic. But nowadays, in this era, we have laparoscopic ultrasounds.
Ultrasound, sir. Yes. Yes. Yes, sir.
If the facilities is available, yes, to some extent, that is one of the ways. Even in open surgery, we can use a ultrasound by which we can eliminate the chances of positive margins. Not totally 100%, but we can. That is one of the main advantages that has come, right, of ultrasound.
Yes.
Intra-op.
Yes, sir.
I think the answers are given, sir. Can I proceed, sir? Kailan, sir?
Please proceed. Please proceed.
So coming to the complications of partial nephrectomy, I'm talking about open as well as laparoscopic. So what are the complications that may happen? Kishore, you are there, right? Yeah.
Yes, sir. Sir, it mainly divides into intra-op complication and post-op complication.
Kishore, wait. You just divide it into intra-op and post-op. So first, we will discuss regarding the intra-op. It will make it more easier and it will be better. So what are the intra-op complications that may happen?
The intra-op complication, hemorrhage may be there, and injury to the renal vessels, and injury to the surrounding structures.
Fine. So coming to the hemorrhage because of injury to the vessels, what kind of complications you expect or you may face? Vascular injuries, vascular related complications.
Sir, mostly, posterior segmental artery may be injured in case of partial nephrectomy, sir, or the and the
See.
significant hemorrhage,
Yeah.
significant hemorrhage may be there,
Okay. Okay.
and
If you see the anatomy on the right side and left side, on the right side, the chances of injury is highest on which vessels?
sir, on right side the inferior vena cava injury may be there, sir.
Yes, of course. And another
Yes,
one is the inferior vena cava injury, mostly because of avulsion of the gonadal vein, right?
gonadal vein. Yes,
That may happen more in radical, but here also it may happen, right?
yes.
On the left side, what you expect? What are the vessel injuries that you may expect?
Sir, left side, left gonadal vein, and sir, aorta may be
The
may
most
have
common or the most dreaded complications that we all fear on the left side is injury to the lumbar vein, as
lumbar
because
vein.
lumbar vein, once it is avulsed, it will go inside the muscle, so it's very difficult to control it. You have to take a figure of 8 suture with a big needle, so and only then it will be resolved, right? Then another thing is injury to the adrenal vein, because we are going to clamp in the hilum, they will be nearby only, right? And third one, you have said the gonadal vein. Gonadal vein is more in the right side in comparison to the left side. Okay. Now, in all type of renal surgeries, injury to the veins is more common in comparison to artery. Okay, arterial injury or aortic injury may happen, but it's very difficult. It is very rare in usually. Okay. Now, these are the vascular injuries that may happen intra-op. What are the other injuries that may happen during intra-op? What are other complications, intraoperative complications?
Sir, opening of the pelvic alveolar system may be there, sir.
That is not a
Or injury
complication that we intentionally do sometimes, right?
sir, and
Other surrounding structures, think of the other surrounding structures.
yes, sir. Injury to the surrounding structure, sir. In case of left side, spleen may be injured, sir. In case of right side, sir, liver, and in left side, the tail of the pancreas may be injured, sir.
On the left side, the injury to the spleen may happen if there is a upper polar tumor. Pancreas,
Yes, sir.
very rare. Yes, it may happen in radical nephrectomy. Right side, yes, injury to the liver in a case of upper polar tumor. But one of the most important thing that you have missed is colon and duodenum. Colon is always medialized. This is the most common organ or the first organ that we always encounter while doing a partial or a radical nephrectomy, right? So injury to colon is one of the common injury that may happen. And second one is injury to the duodenum, right? Okay. So post-operative, what are the what complications you expect?
Sir, post-op, there may be a urinary leak, sir. If there is opening of the pelvic system, and maybe a chances of AV fistula formation, sir. And most dreaded is after partial nephrectomy, the recurrence. Latest complication is recurrence, sir.
Okay.
Recurrence.
Now we'll come to recurrence later on. That is delayed post-operative, right? Now coming to urinary leak, what kind of management or what will be your management protocol in case of urinary leak post partial nephrectomy?
Sir, post partial nephrectomy, I would like to give the conservative management first, sir. Sir, first IV antibiotics and prophylaxis with sir. I want to I will have to stented the patient, sir. These stent placement may be required, and the regular follow up and imaging should be done if there is collection of that side.
Okay. When you will consider for repair of the fistula?
If sir, if it is not it is progressed even if it's stented, sir, then I will go for repair of the system.
See, the thing is that in normally when you stent in a case of post partial nephrectomy urinary leak, the leak may increase. So in that case, the next step will be you need to put an indwelling catheter, right? After putting an indwelling catheter, full diversion of the pelvic alveolar system, if it happens for say in a chronic period of time in the drain, then we may consider for repair. Okay, that has to be done after 3 months. Now in pathology, after the histopathology says that it's a RCC clear cell type, negative margin 5 mm with Farham grade 1, right?
Yes, sir.
So this is what it came. Now, in case there is positive margin, what will be your protocol next? In case it's not positive margin here, but if there is positive margin, what is your protocol?
Sir, we should regular follow-up of the patient, sir. No need of any intervention in positive margins and in partial
Why?
nephrectomy.
Why?
Sir, the study shows that, sir, positive margin have in low-grade tumor, sir, T1 tumor, there is not much progressed or survival benefit is given by surgical intervention in positive margins.
Actually, the thing is that when we do a closure during partial nephrectomy, we take the margin before the closure. So when we do the closure is around 5 millimeter distal to the margin. So once we do the closure, there will be ischemic changes in that part of the kidney. So that ischemic changes will take care of those positive margin. Okay. Now the thing is that there is another concept coming regarding positive margin that you should know. It has not come in guidelines, that there is a concept of microscopic positive margin, or there is a positive margin throughout the tumor bed. In case there is a interval positive margin, say one part of the tumor shows positive margin and later and the rest of the bed is normal, then you should be less concerned. But if there is a whole tumor bed is margin, the whole tumor bed is positive, then in that case your protocol should be more intense. It has to be more intensive, right? You have to do the investigating the CT scan or the other investigations more frequently in comparison to interval positive margin. Okay, this is a new concept that has come regarding positive margin. How will you do a follow-up in this case?
Sir, this is low-risk patients having T1 grade, sir, and 4-1 grade 1. I will have to, sir, first 6 to 12 months, I do a CT abdomen and pelvis, sir, along with routine examination, of complete blood count, serum calcium, lactate dehydrogenase, ESR, sir, and along with chest X-ray, sir.
Till when?
Sir, after 1 year, yearly ultrasound or X-ray yearly up to 3 years, sir.
Okay. In case of a positive margin? In case of positive margin, up to 5 years should be surveillance should be there. Any rule of PET scan?
PET scan, sir, there is no such rule in no such advantage of PET scan in renal cell carcinoma. If the CT or MRI is unequivocal or any doubt, sir, then we can go for PET scan for metastasis. No active role of PET scan in renal cell carcinoma, sir.
Okay. So this finishes my first presentation, sir. Sarkar sir, anything that has to be added? So you are not audible.
Audio off, sir. Kalyan sir's audio off.
Yeah. Sorry. Some little points in the chat box. Manoj Singh asked whether there were any practical implications of nephrometry scores for partial nephrectomy. Are they just practical or theoretical? And Dr. Ashu quite correctly commented that higher the scores, more the chances of complications, more chances of requiring a radical nephrectomy. So the surgeon should be more cautious and counsel the patient. So it's the most important thing is that you can counsel the patient for the procedure. And also the other important thing was that Dr. Shivaji Basu made a comment that it's very difficult even with intraoperative ultrasound to assess endophytic and central tumors, even in more than one center. And if one should inspect the adhesion of the perinephric fat on the tumor. These are indications for converting a partial to radical. And maybe, it is arguable. I often ask the pathologists to inspect the entire specimen straight away after removal. They have better eyes, and maybe there should be a low threshold for the frozen section that you asked for, both of the residual tumor bed and on the main tumor itself, to make sure that you've got the minimum 5 millimeter margin. So these are the points. And Anshuman has a question about trifecta and partial nephrectomy. Is there anything you wanted to make? What exactly do you want?
Jitendra?
Sir, it is positive surgical margin, estimated blood loss, and warm ischemia time, sir. That is given by centrality index score. That is superior. Centrality index score is superior to Padua score and renal score in case of trifecta outcomes of partial nephrectomy, sir.
Okay, back to Dr. Devango. Would you please carry on with your next presentation then?
Right, sir.
And the students, would you please, I was a bit, got a bit connectivity problems, and would the students for the second session, Dr. Vishal Kashyap and Dr. Arnab Maiti, please introduce themselves again and make themselves visible.
Yes. Good morning,
this
sir.
case.
Yes. Dr. Arnab, sir, here.
Yes. Arnab and Vishal will be here, right?
Yes, sir.
Arnab
Yes,
and Vishal Kashyap will be here.
Yeah.
Yes.
Hello, Arnab. Hello, Vishal. So
Yes,
we'll,
good morning, sir. Morning. Good morning,
so
sir.
we'll be discussing on the renal cell carcinoma right now, a new case, right? So
Yes.
can I start, sir?
Please do.
So this is a patient, a 37 years old female, Hindu female from Assam. They presented with a pain in the right flank from last 6 months and with a history of hematuria. Now coming to the present illness, there is a pain in the right flank which was insidious in onset, dilating in nature, continuous. It is non-radiating and it is relieved by medication. There is no history of any lump, swelling or in the flank. There is no history of fever. Yes, there is history of hematuria with several episodes of hematuria with passage of clots present. The shape she couldn't specify. The history of colicky pain is there following hematuria, during hematuria. There is history of weight loss, loss of appetite from last 3 months. There is history of burning. There is no history of burning micturition or fever. There is no history of diabetes mellitus, hypertension, or there is no history of surgery in the past. She is a non-smoker, non-alcoholic, no tobacco, non-waste person. LMP was on 110/21. Then there is a last. She is married for last 3 years. There is no children. Now, coming to the general examination, it's almost normal. There is no edema. There is no the pulse rate is normal. Everything pallor is absent. Abdominal examination, there is no lump. There is no positive finding. Systemic examination, it is normal. So based on the history and the general examination, what is your provisional diagnosis? Yeah, Arnab, Vishal, anyone can answer?
Yes, sir, malignant renal mass, sir. Provisional diagnosis.
Renal mass?
Sir,
Points in favor?
sir, it might be, sir, renal stone, sir.
So provisional diagnosis can be many, all one. So why did you say, Arnab, it's a malignant renal mass?
Sir, pain in the flank and sir, also, sir, the history of weight loss, sir.
Okay.
That, sir, puts more in favor of, sir, any malignancy, sir. That will be a one, sir, positive findings.
Any
And also, sir,
disease, chronic inflammatory disease, you can get weight loss, right?
yes, sir, that is also.
Yes.
Yes.
Vishal, why did you say it's a renal stone? Points
Sir,
in
it is
favor.
the, sir, Sir, it is the young age patient, 37 years old, female patient, and the patient has the history of the pain, dull aching pain, and the patient has the colicky pain is also with the hematuria. So, and is the mention, there is no mention about the significant weight loss. What is the weight loss? Not every weight loss is the suggestive for the emergency. It's significant weight loss. That is the suggestive for the emergency.
Okay.
And the in female, there is the malnutrition. Is there so many? How
Okay.
there is chances of the malnutrition in our community. So it is
Okay.
not too much significant.
Okay, from the history, we cannot say it is very difficult to say the provisional diagnosis, right? It's very difficult. It cannot be, you cannot say directly, you cannot go jump into malignant renal mass from the information that you have got up, right? It's very difficult. Vishal, yes, to some extent you can say it to be renal stone disease or any chronic inflammatory disease, but you have to keep both the things in provisional diagnosis. It can be a renal mass, it can be a renal stone. You
Yes, sir.
cannot say
Yes, sir.
provisional
Yes, sir.
diagnosis is.
Yes, sir.
It can be 1, it can be 2, it can be 5, it can be many numbers. Okay, so you
Yes,
cannot say that, you cannot directly jump. The point is that Arnab, you cannot directly jump into a malignant renal mass from this information, right? So in exams, it's better to avoid. So to confirm our provisional diagnosis, that is a renal mass, or it's a renal stone disease, or it's a chronic inflammatory disease, what are the initial laboratory investigations that you will do?
It will be a, sir, complete blood count, the renal function tests, and sir, the other routine blood examinations like liver function test, the coagulation profile,
RFT.
RFTs I have told, sir.
Okay, everything is normal.
Urine examination.
In routine examination. Yes.
What is a significant finding in urine examination here?
Any infection, sir.
Pardon?
Any infection, any pus cell is present or not.
What is the positive finding here?
Here the RBCs, sir, 5 to 6 RBCs per
RBC is the
So
RBC.
patient is having microscopic hematuria, right?
Yes, yes, sir.
In case it is a infectious disease, what would you have been expect? What do you expect? What will you expect?
Pus cell, more pus
The
cells.
pus cells will be more, sir.
What is a sterile pyuria?
It is mostly seen in, sir, like cases like.
Where you see it. I am asking what is sterile pyuria?
In a sterile pyuria, sir, pus cell is the present, but there is no any growth.
There is no growth. There is no bacteria.
There is no presence of microorganisms.
Conditions where you may get sterile pyuria.
Tuberculosis, sir.
Only
Tuberculosis.
Tuberculosis, malignancy, stone disease.
Malignancy.
Okay, you have a whole list of disease. There are 8 conditions where you may get sterile pyuria in Campbell, right? So you have to remember all those. Now it's there is no growth in urine culture in this patient. Now coming to imaging, what imaging that you will do to a patient who comes to you in outdoor?
The first will be sir, USG of kidney urine, KUB region, sir. First.
Ultrasound KUB you will do it, right? Okay. Ultrasound KUB done. So what is the finding? You have a right renal hyperechoic mass with necrosis within. The size is almost 7 centimeter in mid and lower pole with perinephric collection measuring 8 millimeters. Right? What next?
Next, go for the CECT.
What you want to do? CECT whole abdomen, CT IVU, what or anything else, or an MRI?
CECT.
CECT KUB with urography, sir.
CECT?
KUB.
KUB. Okay. CECT whole abdomen done. It showed a well-defined exovitic round to oval shaped heterogeneously hypodense mass with macroscopic fat density, well circumscribed enhancing capsule along with parenchyma measuring 7 centimeter. The lesion is supplied by the lower segmental branch. It is anteriorly abutting the anterior renal fascia. Medially, it is abutting the right psoas muscle. Here is adjacent surrounding fat stranding is also noted. So it's a big enhancing. I am just summarizing it. It's a big 7 centimeter mid to lower polar mass, which is enhancing and it is abutting all the surrounding structure along with a pericapsular collection. Got it?
Yes, sir.
What is the final diagnosis right now? After seeing all the investigation, the history, and you summarize this case.
Sir, it is the case of the chronic infection, the perinephric abscess.
It's enhancing mass. It's enhancing mass.
Hospital unit is the sir -60 to -80 is the max.
In one part there is -62, but the rest part there it has the enhancement which is more than 35.
But this, sorry sir, this is not mentioned in the CT scan reports.
Yeah, it's not mentioned. Okay, I got it.
If it enhances the more than 30 or 35, sir, so sir, it is the case of the renal malignancy with the perinephric collection.
Yes. What other investigations that you want to do?
Any other investigation, if enhancement is the project, then we rule out the other.
It's 11 o'clock.
Distance metastatic investigation for the.
You want to do a metastatic workup, right?
Yes, sir. Yes.
Yes. So these are the few investigations that has been shown in your screen, right? First is chest CT or chest X-ray, which was done and it is within normal limit. Why we need a CT scan or chest CT or chest X-ray?
To rule out the lung mets.
Pulmonary mets. MRI, is it required in this type of cases or when it is required in a renal mass, localized big renal mass?
Sir, in my case, sir, there is no need of the MRI.
In this case, it's not required. Okay, fine. When you need a MRI?
Sir, if a CT...
Need for, sir, to know for any IVC involvement, sir, if there is any...
IVC involvement or any suspected involvement.
Yeah. MRI in a large renal mass is required.
Yes,
only
sir.
When you are expecting a vascular involvement.
Yes.
That is a renal vein thrombus or a IVC thrombus. Another indication of MRI is that when you are expecting a surrounding structure involvement, right? Like liver, spleen. The reason being that in MRI, the plane is better, the soft tissue planes are better delineated in comparison to CT scan, so that you can plan your surgery. Okay, these are the two indications where you need an MRI for a big renal mass. Okay.
Yes.
Now, bone scan, is it required in this case, or if it is required, when?
Not, sir, it is not required.
It's not required in this case. Do you need bone scan in a renal mass?
Not routinely, sir, not in every case, sir.
Not in
if
every
the patient,
case. Which type of cases you do a bone scan?
But if the patient has any complaints of any bone pain, then only, sir, we will go for bone scan.
New onset bone pain patient presenting after this complaint. The patient has started with this complaint. After that, patient developed the pain, complaining of bone pain, new bone pain. If just early bone pain, then you can consider for a bone scan. When do you need a CT brain in a renal mass?
If the patient has any neurological symptoms or complaints, then we have to go for a CT brain.
Right. Okay. Fine. Now, what will be the treatment in this case?
Sir, I go for the radical nephrectomy.
It's an open or laparoscopic?
Sir, as I am traditional resident, I am the confident in the open radical nephrectomy, so I go for the open radical.
Very good. So we are planning for radical nephrectomy, right? We are planning for open radical nephrectomy in this case. Okay.
Yes.
Now, what is the definition of radical nephrectomy if you go classically?
In radical nephrectomy, remove the kidney with the Gerard's spasser and upper 1/3 of the ureter, and sometimes adrenal is also involved.
Yeah, classically
Also
we
no.
say the definition of radical nephrectomy is what you said, is kidney along with the gerotas with upper third of the ureter along with the adrenal gland, right? This is classical, but nowadays we have some exceptions that I'm going to discuss later on. But the classical definition is always you include the adrenal, right? Now, how will you counsel a patient of radical nephrectomy? The points, the things that you should keep in consideration for before going for surgery.
Hello.
Yeah, Vishal and Arnab, tell me. Arnab?
First, sir, about the attendant risks of the procedure, sir, and also, sir, about the morbidity involved, and also, sir, the recurrence, sir, post present, sir.
Yeah, the things that we need to consider is first the complications that may happen. Yes, what are the complications you have to explain it to the patient? What are the things that you think you have to explain? What is the most important thing that you have to say to the patient?
Bleeding, sir, and also chance of injury to the adjacent organs.
Okay.
Chance of sir not able to be completing the procedure, like
I'm talking about this case. I think in this case you can complete. Okay.
Yes, sir.
The most important thing besides the complications, you have to explain to the patient that patient will have only one kidney after this surgery, right? The chances of having CKD in future, the chances of taking the points that he or she should take care to preserve this kidney function. These are the things that you have to explain it to the patient as well as the attendants before going in for removing any kidney in not only radical nephrectomy, even in a simple nephrectomy also, you have to consider this point. This is one of the very important thing that you have to explain it to the patient. Like in partial nephrectomy, we talk about the positive margin, which is one of the salient thing. Here, we will talk about the chances of having a CKD in futures. So what are the things that she has to do? What are the things she doesn't have to do? What are the things she has to eat before going to OT? Okay, the chances of having CKD,
Yes.
because she will have only one kidney left with her, right? So this is very important thing. Now coming to steps. So what are the steps you can anyone tell the steps? Just enumerate the steps of a radical nephrectomy. Open radical nephrectomy. Vishal, you told that you want to do a radical nephrectomy. So how you do a radical
Yes, sir.
nephrectomy? Just the position, the incision,
Yes, sir.
the main salient points.
Sir, I go for the transabdominal route from the subcostal incision,
Fine.
and first the
On both the sides, if it's a
mobilize
left
the
sided
colon,
kidney also, on right
and
side kidney also.
just after the is it the right side tumor, sir?
Yes, yes. I'm just asking you. You are
Hello.
absolutely right that you will go for a subcostal incision. If this tumor is on left side, then also your approach will be a subcostal one.
Yes, sir. Yes, sir.
Okay, fine.
Left
So
side
you will
subcostal.
go for a subcostal incision. Yes. Then next.
Hello.
Yeah. Next. We are hearing.
Hello.
Yeah. Hello.
Hello.
Vishal, we are hearing you.
Yes, sir. Yes, and next is the mobilizing of the colon. Then I go for the halum dissection, sir. And
No, you directly cannot go for
halum
dissection. Before that, you need to
dissection,
remove
first
something.
we control the vein, and then the
Wait. Vishal, wait. Vishal, wait.
Yes, sir.
After
Yes, sir.
mobilization of the colon, what is the structure that comes on the right side?
Yeah, if it's right side, sir, the after mobilization of the colon, then the cauterization is done for the duodenum, sir.
Yes, cauterization is
And
very important, right?
after
It's a very
duodenum is
delicate structure that you
cauterized
need to
completely,
remove.
and then go for the halum dissection, sir. And after halum dissection, we first. Yes, sir.
Yeah.
So your sound is not. I am not audible, sir. For you. Your sound is
Hello.
not clear, sir.
Am I
Yes,
audible?
sir. Yes, sir.
Yeah.
Yes, sir. Yes. Yes, sir.
Yeah.
After the cooperation, sir. Hello.
Yeah, we are hearing you.
Yes, sir. After the cooperation, sir, the elimination is started and control the renal vein first, and then the dissection for the renal artery. And after renal artery identified and control, and it is the knot and transected. And after that, the renal vein is also knotting and the transected, and then mobilize the kidney from the upper pole and the liver sides, and the lateral mobilization, and in the last you go for the ureter and the gonadal vein.
Why you go for the ureter in last? Can we identify the ureter is a superficial structure? We can detect it and we can clip it.
Yeah, both approach are you could sir. You can do.
Is there any advantage of doing the ureter last?
Sir, if you sometimes, sir, if you dissection the ureter first, there is the chances of the gonadal injury and the other, so it is the cause of the more bleeding and.
Yeah, theoretically, if you clamp the ureter first, the chances of congestion of the kidney because of accumulation of urine is more. That's why theoretically they say that ureter should be done last, right? This is the reason. This is the gonadal vein injury is not the reason. Okay.
Okay. Yes.
Got it. Now the thing is that in such a big tumor, if the tumor is more than 10 centimeter in size, it's a right-sided tumor. Do you think there is any better approach, or there is another approach of dissecting the artery? What you have said is
tumor is too much large and upper, then go for the thoracic.
Pardon?
Hello.
Yeah.
Hello.
Yeah, we are hearing you. Hello. Yeah, Arnav, you can tell. You can take over.
Kindly, sir, what the question, sir, is?
Yes. In case.
Hello.
Vishal, you are back. Yeah,
Yes,
tell
sir.
me.
Yeah. Yes, sir. If there is a very large tumor, sir, and the upper pole was tumor, then go for the thoracoabdominal approach.
Yeah, got it. Thoracoabdominal. I'm asking you any other way by which you can approach the artery. Then what?
Sir, the posterior first approach, sir. We can approach the artery first.
Approach
posterior.
Aortovernal group, sir. We go for
yes. Inter-aorto group, where you can go for the artery first. Even this is the approach that we do in cases of the trauma cases, right?
Trauma cases,
or a very big tumor, we can go for this one, right?
Yes, sir.
Okay, very good. So these are the steps of doing a radical nephrectomy. Anything that has to be asked, Sarkar sir? So you are mute. So your audio.
So I think the counseling part which you mentioned about CKD, and you should always look at the other kidney, and if there's any doubt about the patient being diabetic or hypertensive, I think the AUA guidelines strongly recommend that, especially if the patient has albuminuria or proteinuria, to involve a nephrologist in the decision process. Because of the long-term chances of CKD. You correctly put that point up, and these days there are specific questions both in the counseling for both radical and partial nephrectomy. I think renal function is a very important consideration.
Yes. I can proceed, right, sir? Yeah.
Yeah.
Now coming to the complications again, the complications for partial nephrectomy and radical nephrectomy are almost same. Then also we have to discuss for the sake. So the intra complications on the right side. Yeah, Arnav, what are the vascular complications that you may face or you may encounter during the process on the right side?
So on the right side, sir, there is a chance of injury to the inferior vena cava.
Right.
Also, sir, the lumbar veins, sir. And
on the right side. On the right side.
Sorry, sir. It's not the lumbar vein. Sir, the gonadal veins, the IVC, and obviously the Surrounding structures.
Sometime adrenal vein is also ruptured.
On the right side, if it's a very big tumor, adrenal may be injured, yes, but it's rare on the right side. Then also it has to be mentioned, right? So while we are operating a very large mass, say this mass, and there is injury to the IVC, what is the first thing that we will do in open surgery?
Sir, we prepare for the vascular repair.
Yeah, I got it. You will prepare, but before that, what will you do?
Sir, if you have the facility for the angioembolization, so then you go for
Angioembolization for IVC injury?
No, for IVC injury.
IVC, I'm asking about IVC injury. Intra-op, you are having an IVC injury. What you will do? The first thing.
So first we have to
the compression, sir.
Compression is the answer. Yes, compression. Then, what instrument is used to tackle the IVC injury?
Yes, sir, Satansky clamp, sir. Satansky clamp. Satansky clamp.
Satansky or bulldog, normal. Yes, both we can use, but Satansky is more commonly used, right? Because it's long, it's the curved, so we can use it, right? Bulldog is a single thing that it is not curved, so you have to go inside. Bulldog is more useful in elective cases, and in emergency, Satansky is more important, right?
Yes,
now, what is the suture that you use for a vascular repair for IVC injury?
Prolene 50.
Prolene 50.
Yes, Prolene 50 or 40 you use. Okay, fine. What are the surrounding structures that may be injured on the right side?
Duodenum, sir.
Duodenum.
Right. What is the management of a duodenum injury during intra duodenum injury?
Sir, we first assess the injury. It is the full thickness injury. It's the partial only the mucosal injury.
It's a full thickness injury.
If there is the full thickness injury, then go for the anastomosis.
Anastomosis. It's not complete transaction. It's a full thickness injury, not complete transaction. It's very rare to have a complete transaction of duodenum while doing a radical nephrectomy if you don't intend to do it.
Sir, the full thickness injury is the very little. Then go for the post-op period for the right tube and the NPM for the 3 to 4 days.
Yeah. In how many layers you repair a duodenum?
2 layers, sir.
So 2 layers. What is the suture that has been used?
We are using the Vicryl.
Vicryl, good. So we'll use the duodenum. Then other injuries, other organs?
Liver, sir.
Sometimes liver.
Liver. How you manage a liver injury?
Sir,
first, sir, they compress the lacerated part of the liver. If the bleeding is the control, then it is okay. If bleeding is not controlled, then get the.
We have to go for the Raffi technique. And
Surgical sometimes used for the.
Surgical Abgel can be used.
Can be used. Okay, fine. Then also it's not doing, then we have to repair it, right?
Yes.
And on left side, what are the vascular injuries that you can expect for a big tumor?
Left side, sir, the lumbar vein.
Lumbar veins.
How you manage a lumbar vein injury on the left side?
If so, the lumbar vein is injured, it is retracted, then go for the figure of 8 suture is better in the part.
Yeah, you need a very big needle for that, right?
Yes.
Then what other vascular injuries it may happen on the left side?
So the left adrenal vein.
Adrenal vein, sir.
Right.
Adrenal
vein can be clipped. Okay, then next.
Aorta, sir.
Aorta is very rare on that side.
Aorta is very rare.
Yeah.
Anything
that you can mistake it for renal artery on the left side. You should always keep in mind for a very big tumor.
Yes, sir.
Pardon, sir?
Any vessel that you may mistakenly ligate, thinking it would be a renal artery on left side.
Superior mesenteric artery, sir.
Yeah, that has to be kept in mind always. Okay, it has happened many a time, so it is very important thing that you have to know. Now, what are the surrounding structures that may be injured on the left side?
Sometimes splenic
Splenic
tail of the pancreas.
Tail of the pancreas and the splenic injury. Now, if there is splenic injury, how you manage it? How you differentiate from liver injury? In most of the time, splenic injury cannot be managed conservatively, so you may have
to go for a splenectomy.
Okay, it's more friable than liver. The bleeding doesn't stop sometimes, right? Okay, for pancreatic injury, you have to repair it. Okay. Now, what are the post-op complications that may happen?
Rest of complications are wound infection.
Bleeding, sir.
Okay, bleeding. You the pedicle
Pedicle, if it gets slipped, then
that's an
we can
emergency,
have.
right? Okay. Then other complications, if there may be infection, there may be collection, or these are the most common complications will be there, right? Okay, that finishes the complications. Now tell me,
There's a question from Dr. Ashu that suppose lumbar vein is avulsed, there is bleeding, but the exact vein is not visible. What could be the reason and how to manage? So would Domnov or Vishal, would you like to take it on?
Sir, first, sir, there is a bleeding site, sir, suspected bleeding site, so we'll go for the direct compression. And after the compression, sir, just slowly remove the gauze, sir, and then just localize the site of the bleeding, sir. And we use the long needle, sir, and we got we should get the figure of 8 suture as the bleeding site, sir, for the stoppage of the bleeding.
I think he was trying to suggest that the lumbar vein retracts into the psoas, and how would you manage it? Is that correct, Anshuman?
Yes, sir. Yes, sir. It is correct.
Yeah.
So, can I add one thing, sir? Hello.
Yes.
Samay, sir. Can I add?
Yeah. Please do.
Sir, one situation of lumbar vein being retracted inside. Suppose there is, we are not able to get into that point. There is figure of 8 deep stitches over the psoas. That means it's indirectly compression suture to be given over that area. Sometimes it will be useful in a difficult situation.
yes.
Okay. I think you carry on actually.
Yeah. Vishal and Arnab. So, do you think adrenalectomy is required in this case?
For the my case, sir.
Yeah, this case, yeah.
For the large 10 centimeter upper pole tumors.
This case. This is a 7 centimeter mass in the mid and lower pole.
Adrenalectomy is, depends upon the intraoperative finding.
I'm asking you in this case whether you need it or not.
No.
No, sir. When you will require it?
Sir, if any radiological suggestive for the adrenal metastasis, intraoperative finding, you have doubt that adrenal is the involvement, then go for the adrenectomy.
Okay. Arnab, you want to add anything?
Sir, the large upper polar masses, where intraop, if we find that there is a high chance of the adrenal being involved, then we should go for a adrenalectomy. But otherwise, sir, a routine adrenalectomy is maybe not required, sir, in this case especially.
I got this flow chart. So you can divide it nicely into the radiological things, radiological points. The venous radiological points are if there is irregular borders in of the adrenals, there is nodule, there is enlargement, there is contiguous infiltration. Venous involvement, if there is involvement up to the level of adrenal vein. If the renal tumor is of upper polar tumor or it's a more than 7 centimeter tumor, then you need a adrenalectomy. So these are the points where you do adrenalectomy. Otherwise, we don't do adrenalectomy nowadays, right? So how you follow up this case?
Follow up the routine investigations, sir. CBC, LFT,
duration,
RFT, EGFR, and after that, and first.
Okay, 3 monthly. These type of big tumors we do a 3 monthly, into 3 monthly checkup. So what are the investigations that you will do on the third month?
At the third month, sir, the first investigation is I did the radical nephrectomy. So after this, I go for the CT, MRI.
CT or MRI?
Follow.
CT.
CT.
Yeah, and blood investigations. You told.
Blood investigation, CBC, LFT.
Chest X-ray required.
Chest X-ray, yes, sir.
You have to do a 3 monthly checkup, follow up till when? How many years?
Up to 5 years.
5 years or 2 years?
2 years, sir. 2 years is, sir, 3 monthly. And then, sir, annually thereafter for up till 5 years.
5 years. Okay, fine. Sir, that finishes my second case.
Thank you very much, Devango. Any of the other faculties, anyone, any senior teacher, do you have any questions to ask with respect to this large renal mass?
Okay. Sir, I think very elaborated discussion.
I think it's been very elaborately discussed, and thank you very much, Dr. Devango. So, Samir, it's, the third case is yours. So, you are going to present a case now, and your students are students are Ankit Verma and Ajit Gupta.
Thank you, sir.
Yeah. Thank you very much, Devango. And Samir, over to you.
Am I visible?
Indeed, you are visible. And Samir and Ajit.
Is it visible now?
Yeah, and they are both visible now.
So, who are the candidates? Kindly introduce.
Yes, sir. I'm Dr. Ajit Gupta.
Yes, sir. Dr. Ankit Verma from IPGMER, Kolkata.
And Ajit is from?
Yes, sir. I'm from Fortis Hospital, Kolkata. Good morning, sir.
Fortis, okay. So, you must have listened all the discussions beforehand.
Yes.
Yes? Yeah. No, actually, almost all angles of presentation, approach to case, and management is almost discussed by Dr. Devango. So, I think I should be more focused to a specific point rather than repeating those same things. So, let's start our presentation.
Yes.
So, Ajit, this is a patient that presented to us. What do you think? Ajit?
Yes, sir. This is a case of 65-year-old female patient who complains of left side loin pain and for 6 months and having fullness on for left loin for 3 months. I'm suspecting of grossly hydronephrosis on the left side, sir, in the first instance.
What do you feel? It is we may be discussing on the neurological points, not non-neurological cases may be sidelined. Okay, just tell me what are the things that coming to your mind?
Grossly hydronephrotic.
One is hydronephrotic kidney.
Yes, sir. The second is large renal SOL.
Large renal mass. Anything else?
Retroperitoneal tumor.
Retroperitoneal tumor. Okay. Okay. Ankit, you want to add something or still you are?
Go with the same. Retroperitoneal tumor, any renal SOL, or gross hydronephrosis due to the.
No, he has already told. So just add anything else, anything extra you want to add. No. Yes. Okay, next. So these are the history of vaginal lines. So it was a dog-like pain on the tree, almost localized pain, no significant aggravating or relieving factors. That's why the presentation is 6 months and almost a visible or a documented mass from the patients. It's not the documentation from clinician, it's the documentation from the patients. When patient is documenting a mass, it is obviously should be a big one.
Yes,
okay. Sir. Okay. So there is history of nausea and vomiting, and there is loss of weight and appetite. No other significant histories. You want to ask anything else? You can ask me. if you want to know something extra or you want to have any detailed knowledge about the patients, you can ask me any questions. You are satisfied?
Any comorbid conditions?
Yeah. She is having a known case of diabetic mellitus without any other comorbidities. And almost diet is normal, bowel bladder habit is normal. Here, the patient is complaining of loss of weight. How you will assess a patient's loss of weight? What are the criteria? What are the parameters?
So more than 10% loss of weight over the past 6 months, and we quantified the appetite also. How much she used to take when she was normal, and how much like chapati, how much has been reduced, and the loosening of the clothes can also to assess the loss of weight.
Also, you can ask the attendant or family members so that they can have some feedback.
Yes.
Okay.
Yes.
Okay. So with this past history and what are the history completely available to you, still your diagnosis to be same or you want to change anything?
So most likely the provisional diagnosis now will be some malignant etiology.
What is malignant etiology?
Of renal.
You are Ankit, na?
Yes, sir.
Yeah, okay. One is malignant etiology. Next.
So any chronic infective conditions,
like
chronic inflammatory condition,
like
genitourinary tuberculosis.
Tuberculosis, okay.
Genitourinary pyelonephritis maybe can be there, but then still.
Pyelonephritis. Anyway, probably we cannot treat it because there are no other history like that will suggest of any sort of infection.
Yes, and then I will go for only two differential diagnosis, that is large renal SOL and genitourinary tuberculosis of the kidney.
Tuberculosis. Why not retroperitoneal mass is out? Why? You have not examined the patient till now. And why the hydronephrosis or cystic mass is out? All should be included because you have not examined the patient till now. Okay, and the sequence may be changed. Have you seen the cases of GUTB in your institution?
Yes, sir, I have seen yes, sir.
GUTB.
Yes,
how many of them had loss of weight and appetite?
I have seen only 2 cases, sir, and I have not seen.
Okay, then it is quite low. Quite low. Ankit, do you have any idea?
Yes, sir. Not many patients present with the conventional pulmonary tuberculosis symptoms.
Okay. Yes, yes. Actually, in GUTB patients, the presentation of loss of weight and appetite, they are quite not common as comparison to the pulmonary tuberculosis. Okay. So GUTB maybe you can make it later. So next, this is the general examination. Probably not contributing anything, any significant points. Systemic examinations also normal. Abdominal examination, that's true. This is the inspection finding. Just have a fullness over the left, mid and lower abdomen, and it's almost occupying whole of the left side of abdomen. Palpatory finding is this much, and if you want to know anything extra out of this slide, just ask me. Or still, what are you? What is the specific points you want to add? Okay.
Sir, we can check for the shifting, differentiate between the intraperitoneal mass. It is definitely it's retroperitoneal because we can able to insinuate the fingers between the mass and the right costal region.
And I also want to know whether the mass is palatable or
Sorry,
not.
this is no, they are wrongly written. This is left. This is
Right. Right question.
This is left coastal actually. The left lumbar region. By mistake, this has been written right too. Be
I want
first.
to know the
Anything else you want to ask?
I want to know the palatability of the
Hello.
mass.
Okay, just tell me again.
Whether the mass is palatable or
You
not.
want to know the palatability of the mass.
Yes, sir.
Okay. Just tell me what is palatable.
It is a by manual
Palatability of
examination.
the kidney. Yes, it is by manual examination.
One hand is placed just behind the kidney area.
Just
posterior.
first tell me when to examine palatability. When to examine. Then only we can go for examination.
If the loin mass is palpable, then only we can go for palatability tests.
Actually, when it is a very small mass,
yes,
or it's not very clearly felt on palpation, then only palatability is done. When clearly big mass with obviously palpable or is recognized by the patients, in that case palatability is not a point to be added in the clinical examination, because palatability means when you push your finger from below, the mass will touch and go to the upper hand. That's it.
Yes, sir.
Then how in palpable mass you want to know palatability? You got my point?
Yes, yes.
So palatability a point should not be discussed here. Okay.
Yes.
So consistency is firm to hard, surface is smooth. Now, will you like to continue the same diagnosis, or you will change your diagnosis sequence?
As the mass is formed to hard, so the cystic nature of the mass of the
mass can be
has to be excluded.
Excluded. Okay. So anything else you want to know? Shifting dullness is negative.
No, sir. No, sir.
Bowel bladder sound is normal, no buoy. So what do you want now?
Pardon, sir?
Sanjit,
yes.
What next you want to know? Examination is complete. Almost no other systemic finding except the mass. How do you know this is a kidney mass? Ajit, how do you know this is a kidney mass, and how?
The mass is on the left side and it is moving with the respiration. The first thing, and the finger can be insinuated between the left subcostal margin and between the mass. Second thing, and the mass is lying over the kidney area. Third, and there is bowel present over the mass.
No, the mass is not present in the kidney area. It is occupying whole of the left abdomen, so may not be in the kidney area. Okay. How do you differentiate a mass of retroperitoneum and intra-abdominal mass? What are the tests you will do?
In knee elbow position, the patient is placed in knee elbow position. If the mass becomes more prominent, then the mass is intraperitoneal, and if there is no change in the size of the mass, then it is retroperitoneal.
So what next?
I will extend my. I will do an ultrasonography of the whole USG KUB region as an extension of the physical examination.
Okay. So this is the ultrasound image is not available. So I put the reports. Right kidney, almost everything is normal. So left kidney is a huge mass of 20 into 18 centimeter with irregular outline and heterogeneous. echo texture, almost occupying the left renal fossa and left half of the abdomen. What next you want to do?
Then I will go for blood investigation, sir. And
Yes.
routine urine examination along with culture and sensitivity.
Why?
Because I want to do a CT scan of the contrast enhanced CT scan of this patient. So I would like to know the status of
So
kidney
your aim is to confirm the ultrasound finding.
Yes, sir.
In relation to the CT imaging. Okay. Ankit, what are the abnormality in this slide?
The
Random blood.
patient is diabetic. The RBS is on the higher side.
Okay.
And so albumin is a little bit low on the lower side.
Okay.
And sodium is also, sir. The patient is having hyponatremia.
Okay. These are the two tests available. So anything else you want to know? Investigation panels are complete. Culture was negative.
So creatinine.
Creatinine was normal.
We would like to proceed with the CT scan, multiphasic CT whole abdomen.
Okay.
To confirm the nature of the growth. The
So would you like to go for any other investigation at this point of time, or you will go for CT scan first, and why? Would you like to go for any other biochemical test? Because in ultrasound, almost it's a renal mass, or maybe
so the serum calcium and LDH level usually we do in the suspected RCC case. So already been mentioned here. In the next slide.
So would you like to go for any other investigations, or your investigation panel is complete?
No, sir. I will go for CT.
Yes.
Yes.
CCT.
Yes, sir.
Okay, we'll discuss again. This is the CT image. Just read this one, and I will go to the next slide. Ankit and Ajit, both are okay?
Yes.
Yes, sir.
Okay. This is the axial cord.
Yes.
Okay, so what do you want? What is your impression now? Ankit, just tell me what is your impression?
So CT plates are showing large left renal mass with heterogeneous ecotexture and peripheral enhancement, and in center there are area of heterogeneity, most likely due to the necrosis.
Okay. Just tell me, student first. Quickly. Anything else, Ajit?
The enhancement of the mass is lower than the enhancement of the normal parenchyma on the left side.
Okay.
And, this is heterogeneous ecotexture mass.
No, anything extra you have seen, or just will to
So
next
the
one?
invasion of psoas muscle might be present.
Special invasion is almost there. It is not clear. One slide on the right side, it's almost abutting the source, and almost the margin is not clear. What about the lateral wall? Is invading or
yes, sir, it's invading. On the first, it's been some slight invasion seen, but on the next slide, the definite margin can be seen on the lateral side of the tumor.
In the lateral aspects, almost not invading the other part,
Yes,
because the margin is clear. But in one slide, the source supposed to be involved, because that
Yes,
is not
sir.
clear. What else extra you want? What extra in city? Be quick.
So IVC involvement, but in this slide we cannot comment. We need the arterial.
Okay, you just so the upper three plates on the right side, and tell me.
In the fourth slide, we can see that there is a tumor thrombus.
Can you appreciate the renal vein?
No.
Then what is the
Yes,
tumor
sir.
thrombus? This is left side mass.
Yes, sir.
Then where is the tumor thrombus? Can you appreciate my pointer?
Yes, sir.
Yes. What are these two?
This is the renal vein, sir.
What is this?
This is aorta, which one you pointed just right now.
What is
Aorta has been displaced. Aorta has been
What is
displaced
this?
laterally, sir.
Okay.
The renal
And what
vein,
is this two?
renal vein, and the aorta adjacent has been displaced laterally to the right side.
Okay.
And this is elongation of the tumor in the renal vein.
Now, what is this two? Tell me these two. Yes. Why are you in doubt? Where is the exact position of the vein? Where should be the vein?
This is
the vein should be somehow near this region. Okay.
Yes.
Yes or no?
Is this intra-aortocaval lymph node, sir, or hilar lymph node?
Okay. Intra-aortocaval. This is the left side mass, and it's the lateral to artery.
Periaortic.
This
Lateral
is
aortic
aorta.
and anterior aortic lymph nodes.
So it cannot be intra-aortocaval. Okay. This is the left side mass. This is the abdominal aorta, and these are the lymph nodes. So this is
Lateral and anterior aortic lymph nodes.
okay. So what next? What is the stage till now? The stage the disease and diagnosis.
T4 N1 M0.
M0. How will you know M0?
Sir, it is MX.
Yes, MX. Okay. Is your slide is complete, or you want to know anything else, or any other test you want to do? The aorta is displaced.
I want to
Vein is
know
almost
yes,
suppressed,
sir.
okay?
I want to know the level of if there is any thrombus in the IVC or not. So I will go for MRI. In CT scan, the IVC thrombus is not clearly seen.
Achha, you want to do MRI. Achha,
Yes.
your findings are complete, or still you want to add something? Only I am telling the positive findings. Rest are normal. Your positive
So
findings
there is
are
cystic.
complete.
There's some lesion in the right kidney also.
Yes, you have missed it. Okay. Rest are normal. There is small cyst on the
yes, sir.
The medial side of
right
the
side. Yes. Look, any abnormality you should pick up during examination, and you must tell that thing. You can tell this is the C shape and these are the positive findings. Rest are normal. That's also okay. But positive findings should not be missed. Okay.
Yes.
Okay, sir. What next? Your stage is? What is the stage of the disease? This is renal mass, probably malignancy. T4
N1 MX.
N1 MX.
N1 MX. Okay. Okay. What next? What next? What next? Tell me, sir. Be quick, huh? We'll have to complete it within fixed time. What test you want to do?
I will go for MRI, sir, to know whether that
MRI has not been done. In this case, MRI not done. Look here, the vein is not clearly seen, and almost all the axial cord, the vein is normal. If the vein is compressed and there is usually appreciated in many of the cords or axial cord or maybe in coronal section. But when the vein is not clearly appreciable, only when it is compressed. Second is there will not be any tumor thrombus in the renal vein. Big mass with renal vein being compressed is less appreciable in a case rather than a case of renal vein thrombus. Okay. So less likely we may get in this type of case, chances of getting renal vein thrombus is quite low. Okay, this is a finding, positive finding as regard this clinical picture is concerned. Are you getting my point?
Yes, sir.
Yeah. Yeah. You just know if renal vein is compressed, it's not easily appreciable in CT. The radiologist can give some idea, but probably for us it's really difficult. So what next test you want to do?
I want to do a CCT chest, sir.
CT chest. CT chest has not been done. The chest X-ray has been done.
Is it normal, sir?
You did it?
Yes,
Do you feel any abnormality?
No, sir. It is within normal limit.
More or less normal. Some sort of hilar markings.
Prominence is there, but that is okay, sir.
Not significant.
Yes, sir.
This is abdominal X-ray, not. What about renal ultrasound with IVC, doctor?
It can be done preoperatively to confirm the any involvement of IVC from the thrombus.
Okay. Between Doppler and MRI, which one is better in which situation?
If the mass is not abutting the IVC, we can go for MRI. And if the mass is abutting, we can go for either for pre-op IVC Doppler or we can go for intraoperative TE.
No, in MRI is almost been better as compared to Doppler, but how Doppler will be beneficial in specific situations?
Sir, to assess the superior margin of the thrombus, MRI is much better and can be diagnosed. You can know about the superior extent of the tumor thrombus through MRI.
Okay. What is a bland thrombus?
Sir, the bland thrombus is the part of the thrombus that attend to the IVC is not part of the tumor, and it does not attend the contrast enhancement on the CCT or MRI. And the prognosis changes significantly if it's tumor thrombus. Then the tumor prognosis worse. But
okay. So in order to differentiate between the IVC thrombus and IVC wall invasion, how to approach IVC wall invasion and IVC thrombus?
the MRI would be better in
MRI
differentiating.
would be better. So clinically, as of now, what your still your diagnosis is same and stage is same. Is
Yes.
Yes. Okay, then what, any extra investigation you want to do, or you can plan your other management?
We can proceed for surgery. Further
We'll
management.
proceed for surgery. Okay.
Yes, sir.
Both of you agreed?
Yes, sir.
We'll
Yes,
proceed for surgery. What is paraneoplastic syndrome?
The paraneoplastic syndromes are syndromes associated with renal cell carcinoma. There could be increased ESR, anemia, hypercalcemia,
So
Stoffer
those tests are not done completely. So would you like to do all these tests or directly go for surgery?
So initially serum calcium was done, LDH was done. It was in the previous slide.
LDH will depict the.
It just tell about the tumor load.
Okay.
We usually do serum calcium. It was 8.5. It was not on the higher side.
Okay. Any ESR?
Yes, sir.
What about PCV? What is hepatorenal syndrome?
So it is also Stoffer syndrome. It's non-metastatic in liver impairment in the case of RCC.
No, I am telling hepatorenal syndrome.
In case of deranged liver function, the kidney function is deranged.
Okay, it is just opposite to
Stoffer syndrome, sir. It is just opposite to Stoffer syndrome.
So before going to further management, you must look for any sort of paraneoplastic syndrome, specifically in case of RCC. Okay.
Yes, sir.
So since the patient doesn't have a specific abnormality clinically, but still this should not be omitted, and this is a fairly large mass. So I think all investigations should be completed before directly going for surgery. So next, what is your plan? So suppose everything comes out to normal, all the investigations, including parameters, the performance status is good, and patient is fit for surgery, or whatever the management you want to give. So just tell me, what is your plan now?
I will go for open transperitoneal radical nephrectomy, sir, of the left side.
Okay. Any extra opinion? Just tell me, be quick, or else we can directly go for surgery. What
Yes,
is the role of? Do you feel any role of neoadjuvant therapy in this type of mass and positive lymph nodes? What is your opinion, Ankit?
So not as such much beneficial. Neoadjuvant therapy as such not much beneficial. Although it can be tried in clinical trials.
Okay. Okay. So your aim is not to go for any sort of neoadjuvant therapy. Would you like to go for biopsy first and manage this case?
No, so there is no need to do biopsy.
Okay. Again, third point is, suppose the patient is having one long nodule or multiple mets. Still your approach is same, or you will change your approach?
In case of metastasis or multiple metastasis, we will start with immune check inhibitor, sir, which is recommended in guidelines.
Okay.
Then I will look for the response. If the tumor size is decreased to more than 30%, or the patient, then I will plan for this surgery.
Okay. So your plan is to go for surgery. Okay.
Yes.
Okay. So before going for surgery, what are in your mind? You will plan beforehand, because this is such a big tumor. Your approach will be, what the open surgery? What is your approach? Transperitoneal,
Subcostal extended
subcostal,
subcostal, transperitoneal.
extended subcostal, transperitoneal. Okay. Okay. Then would it be beneficial to go for a midline incision in such a big mass?
Yes, sir, we can go for that, but I feel comfortable in doing these kind of masses through extended subcostal incision. So I'll go for it.
Okay. Okay. So in subcostal, how will you dissect the lower level of mass? Because it's almost going towards the lumbar or maybe towards the pelvis. The mass is quite big one.
First, I will mobilize the colon, descending colon medially.
Okay, then almost steps of surgery has been already completed by Dr. Devang. So just briefly tell what are the significant important points or important steps in surgery in such a big mass. Just few salient points you tell me, not to go into detail.
So taking care of the lumbar veins, and we have to go for adrenalectomy. So adrenal vein has to be taken control of.
No, you mobilize the colon. Okay,
Yes,
mobilize the colon. Then next step is to mobilize the mass from below and adrenal. You want to tell that one?
Initially, I will dissect the hilum, sir. I will dissect the hilum and isolate the renal artery and vein. And then I will mobilize the mass from the superior.
What clinical abnormality you expect in this type of big tumor?
Sir,
Now,
in this
small
case,
renal mass and such a big renal mass.
Yes.
What extra you expect something extra during your initial dissection? Have you seen such a big mass in during your career?
Yes, sir, I've seen it.
What are parasitic veins?
Yes, sir. The
Such a big mass, usually there are multiple number large veins that usually occupies the whole of the surface of the kidney. So there is a heavy chances of bleeding during the initial dissection. Even reaching towards hilum is quite difficult. So this is a clinical point you must remember when dealing with a large mass. If veins are not present or not significant, then probably your surgery will be easy and blood loss is quite less. But expectation is that in almost all cases, the veins and veins will be multiple, large even ones. These veins will be at the caliber of gonadal vein minimum. Okay, the size of gonadal veins and these surface veins will be almost equal or maybe bigger. So chances of bleeding is quite high. So meticulous dissection and dissection towards the hilum is first important point. Why hilum dissection is important? Ajit?
In case of any inadvertent bleeding or excessive bleeding which we cannot control, we can directly go to the hilum and clamp the vessels, and that will control our bleeding on this collateral vessels.
Do you feel this venous bleeding will stop when you clamp the hilum? En bloc clamping of the hilum?
No, sir, not in block. We will. I will clamp the renal artery as well.
What problem you expect during hilar dissection in this case? because this is not a normal. You are expecting multiple veins, number presence of hilar lymph nodes, clinically significant hilar lymph nodes. What problem or what difficulty you expect during hilar dissection?
There may be inflammatory adhesion in dissecting the
There
hilar.
may be chances of gross adhesion or maybe very difficult to get into that plane.
Yes,
So
sir.
careful dissection, most important. You can go to the lower part, lower border and upper border of the mass, including adrenal area or maybe low down. If the lymph node is quite big, have you seen the video of last yesterday evening?
Yes,
Lymph
sir.
node?
Yes, sir.
Yeah. That has been done in laparoscopy. Similarly, initially the lymph node, if it is occupying almost the hilum, you may need to take out 1 or 2 lymph nodes from the beginning so that your hilar area is clear. Or else unnecessarily there is a chance of injury or maybe difficulty, or there will be significant blood loss. So hilar dissection is important. Venous control is important. Next, you have controlled the hilum. Then next, what extra precaution you will take in dealing with such a large mass?
There may be chances of injury of spleen on the left side. So we
Yes,
will
chances
like,
of injury to spleen. Yes. Second is
injury to the pancreatic tail.
injury to the
can
pancreatic tail. Okay. Okay. So these are the two important issues you must be prepared beforehand. Suppose there is an injury to spleen. What you will do?
I will assess the grade of the splenic injury.
Okay.
And if it is of lower grade, I will do a splenography. And if it is still not controlled with the splenography, I will go for splenectomy.
Okay. Okay. Suppose the mass is encroached towards the tail of pancreas. Almost encroached or it is involved the pancreas.
Yes, sir.
What you will do?
I will go for distal pancreatectomy and
Distal pancreatectomy
with splenectomy.
Splenectomy if required, or else you can go for distal pancreatectomy. Suppose this is a mass on the right side, same type of mass region on the right side, and involved the duodenum. And
then I will yes.
And what you will do? And suppose it has involved the pancreatic head, what you will do?
In this kind of debilitated patient, I will not go for Whipple's, which may be indicated in this case. I will just go for gastrojejunal bypass, and I will leave the mass as it is.
Okay, best and tactical answer is to take the help of general surgeon or J surgeon, but the principle is to be decided by us, because it's a purely a urological case. So pancreatic duodenectomy can be done. What is the chance of survival benefit? Suppose this is a kidney mass encroaching towards the pancreatic head or pancreatic region, and de novo pancreatic mass. Which one is better?
Pancreatic mass in de novo
One is a pancreatic mass, and second case is pancreatic mass due to renal mass invasion. Maybe it's a locally spread. Prognosis wise,
yes,
which one is better?
I think the pancreatic de novo mass is more has worse prognosis than the secondary.
Yes. De novo pancreatic mass is a worse prognosis. Okay. So in this type of big mass, these are the points you must know, and how to deal with the situation, and how the clinical the acumen you need. Suppose such a big mass on the right side, and your vein is IVC is not clearly clearly it's not clearly dissectable, or the margins are not clear. What specific point you want to highlight?
I will go for intraoperative color Doppler.
Color Doppler.
Yes, sir.
No, nothing. What extra you will do?
So complete mobilization of tumor and we pull it up, so
Okay.
that we can ascertain the hilum and take
No,
better.
it's better to dissect the IBC from below. Below means you may go for the bifurcation at the level of bifurcation. That is the benefits of midline incision in such a big mass. Yes, this can be tackled with a subcostal incision, but sometimes if in a big mass, delineation of IBC from below, maybe up to the bifurcation, and then you trace it up towards the renal hilum and maybe up. These are technical points. Suppose this in this case, left-sided mass with a tumor thrombus in renal vein, which you encounter intraoperative. What you will do? This is level 1 thrombus you encountered during surgery.
I will look for the distal end of the tumor thrombus. If it is palpable, I will put a clamp on the renal vein. I will remove the tumor along with the tumor thrombus.
Suppose the tumor thrombus is not palpable and is almost going towards the renal ostium, or maybe just peeping out towards the IVC. Because palpation in this type of renal vein thrombus is quite dangerous. So heavy you may feel it. Palpation in both the thumbs, and it's not clear. Practically, it's not good to palpate whole of the thrombus because there is a chance of dislodgement. Okay. So what you will do? Suppose you are not able to get into the distal end of thrombus.
Then after taking control of the inferior and superior IBC along with the contralateral renal vein, I will do covendotomy and I will pull out the tumor thrombus along with the kidney tumor, and then I will repair the IBC and I will do that.
Any other opinion? Any other opinion? Your plan was to go with the subcostal incision, no?
Yes, sir.
Yes. So with that incision, you go to the IVC control.
So we have to extend the incision. We have to extend the incision on the opposite side, convert it into a chevron incision for IVC.
You want to convert it into the bilateral chevron incision, and you will take control of the IVC from opposite side, from the right side. Okay. From left side, controlling of IVC is not possible. Okay.
Yes, sir.
Even if you mobilize over the colon, over the pancreas tree, it is not possible. So IVC control to be done from the opposite side. Okay. Suppose this patient there was a bleeding, intraoperative bleeding when dealing with the upper pole of the mass. What might be the cause?
Laceration of splenic capsule or splenic laceration may be one of the causes.
One is splenic laceration. Second,
the second is adrenal parenchyma injury.
Yes, repeat please.
Adrenal parenchymal injury.
Adrenal parenchymal injury, and adrenal is almost taken out with the mass. No, it's a big mass. You have to take out the adrenal. Chances of injury to splenic vessels. Okay.
Yes.
Yes.
In splenic vessels injury, splenectomy is to be done. Okay.
Yes.
On the right side, suppose the mass is quite big and chances of bleeding when during hilar dissection. What are the causes? Right, hilar dissection of such a big mass.
Hepatic parenchymal.
One is
hepatic insuffficiency.
IVC injury.
Hilum.
IVC injury.
IVC injury, because IVC injury is clearly seen, because you have to define the IVC before the complete dissection of the mass. IVC, without defining the IVC, the dissection should not go on the right side beyond hilum and any other areas, because once IVC is injured, it's very difficult to control and get into other parts. So defining IVC is a very crucial point in managing such a big mass. So chances of injury to the gonadal vessel, sometimes the insertion is quite high up. Second, chances that there are possibility of small veins that may be a direct tributary to the IVC. Those are the points. In that case, you can put some gauze paste or pack that will be suffice. Third is upper part of the hilum, there is a chances of injuring the adrenal vein. So these points has to be kept into mind. On the left side, upper pole dissection, chances of bleeding is sometimes unexpected. And on the right side, the hilar dissection is sometimes unexpected. Okay.
Yes.
So this is the histopathology of the patients. Lymph node is negative. Hello. Okay, tell me, you have to complete. It's almost time. Hello.
Yes.
Sir, we have to follow up the patient.
I have to follow up the patient. So what about the lymph node? It may be reactive.
Lymph nodes. Yes.
It
Sir,
may be
lymph nodes were
reactive
removed,
or,
but they were not assessed. That is NX.
yes, NX means it's not assessed. Okay. Or else, or
Sir,
what happened?
Improper sampling of the lymph nodes.
No proper marking of the lymph nodes.
Yes, not proper marking of the lymph nodes, or maybe misplaced. So, but as a clinical scenario in this type of case, it is expected to be a positive lymph node, even if it comes out to be negative or it may be reactive. But clinically, such a significant lymph node has to be a positive one. So,
Yes.
any adjuvant therapy you want to do?
No, sir. In chromophobe RCC, might not have any of the adjuvant therapy.
Which type of RCC is amenable for chemotherapy or radiotherapy?
Clear cell or papillary variety?
Clear cell is chemosensitive.
The sarcomatoid
No, sir,
differentiation, sarcomatoid differentiation are amenable for the chemotherapy.
Okay. What follow-up protocol? Is there any difference? What Dr. Devanga has told? Would you feel any difference to go for follow-up, or it's almost same?
It's almost same.
It's almost
So
same.
it's
Samir, we have to finish now.
Okay. Yes, sir. Yes, almost time. Thank you.
Well, thank you very much, Samir. We'll go on to the last case of the day, which is on metastatic RCC, and we'll ask Anshuman to take us on. If he could finish it in 5-10 minutes, we could do a few MCQs, or we'll omit the MCQ session. Please start, Anshuman.
Good afternoon, everybody. I think I'm audible.
You are.
And my screen is there.
We can see it.
Okay. So who's the student in this section? I think it is Dr. Dhan Sagar. If he's present, kindly.
Yes, sir. Myself, Dr. Dhan Sagar, sir. Dr. Dhansagar Vakre from IPGMR Kolkata. Am I audible, sir?
Yes, you are audible, but you are not visible on your video also. Yes, you are. Okay, so you are the only person in this session, I think. Anyway, if other students who are also there and they want to contribute, they can whenever they want to. Okay, so let's start with the case discussion. Ready, Dr. Dhansagar?
Yes, sir.
Okay. So this is a 48 years female presented with dull aching pain in left flank, occasional hematuria, sometimes with small clots. She complains of reduced appetite, there is loss of body weight, and there is occasional low back pain associated with all these symptoms. She is non-diabetic, non-hypertensive, no relevant family history, no history of graveluria, turbid urine, or tuberculosis. And the bowel habits are normal. There is no addiction also. So on physical exam, I'm not going into the details of history and physical examination because everything has been discussed so far with 3 case presentations already done today. So coming to straight to the physical examination, the build and nutrition is below average. The pallor is present. There is no pedal edema, jaundice, or clubbing. There is no significant peripheral lymphadenopathy. On abdominal examination, the left kidney is large, palpable bimanually, firm, non-tender with restricted movement. Liver is just palpable, which is non-tender. The spines are normal. There are no evidence of any neurological deficit. And the chest on examination is normal breath sound. So what would you like to do next, Dr. Dhansagar? Anything, any specific thing you want to add in the history or anything you want to ask in physical examination?
Sir, as the patient is 48-year-old female patient with a left flank pain, with a history of hematuria, and there is occasional history of low back pain, and with the positive history of reduced weight and appetite. So I would consider it as a first diagnosis as first differential diagnosis as a renal SOL with a probability of metastasis. So according to this, I will plan my next examination. As examination does not show any positive findings, so I would like to confirm my examination findings with the ultrasound of the KUV region with as a extension of my physical examination. First.
Okay. Okay, this is the ultrasound picture is not available. This is the report of the of whole abdomen, and it says 12 by 10 centimeter heterogeneous growth involving the left kidney. Right kidney is normal. There is solid SOL in liver, urinary bladder, uterus, adnexa, and other organs of the abdomen are normal. So what now?
So, sir, the USG is suggestive of heterogeneous SOL and one nodule in the liver. This is mostly a metastatic case. So I would like to proceed with the blood investigation first. Complete hemogram, CBC with ESR, and renal function test, liver function test, urine routine examination.
Okay. Anything else on blood examination that you want to know? You are suspecting a metastatic RCC here.
Sir, yes, sir. Level of serum calcium. And
anyway, you are not suspecting a metastatic RCC, serum calcium, LDH. These are all important. Yeah, paraneoplastic syndromes, hypercalcemia. Yes, so these are all part of routine blood investigations done in any case of renal SOL, especially in large renal SOLs. So these are the findings. You can see there is anemia, hemoglobin is 8.5%, total count is normal, ESR is raised, blood sugar is normal, creatinine is within normal limits, bilirubin slightly high, the liver enzymes are normal, electrolytes are normal, calcium normal, urine routine almost normal, and on culture there is no growth. Now what?
So platelet is missing, sir. Platelet is the
Okay,
important.
why platelet is important?
So platelet for the
Because it is one of the criteria for IMDC risk stratification, sir.
Very good. It is
So
prognostic points, so it should be there, or it is also within normal limits. Okay. Now further, how would you like to proceed now?
sir, chest X-ray is also showing one nodule. So I would like to.
Chest, there is single nodular area. So you would like to do an X-ray chest in this case, or any other imaging investigation? What other imaging investigations you would like to do? You have been given the ultrasonography report. You have been given the blood and urine pictures. Now, what further imaging investigations you would like to do in this case?
Sir, I would like to do, as the serum creatinine is normal 1.2, I would like to go with CECT of thorax, abdomen, and pelvis, sir.
Okay.
It will tell me both chest metastasis, the status of liver, and the renal as well.
Would like to do now chest X-ray.
What, sir?
So you don't want to do a chest X-ray now?
Sir, chest X-ray, you already showed, no, sir. That's why.
Showed it. This was there in this slide, but what does the recommendations say? Is chest X-ray needed here or not needed?
Not needed, sir.
Not
so when is chest X-ray needed in renal cell carcinoma patients? In which patients you
Sir, in the
with only chest?
in the low risk.
Before planning low risk cases.
If patient has no symptom and the patient is the low risk, then it is the chest X-ray.
Especially only in the clinical T1A cases where there are small renal masses, we can go ahead without a CT scan. Otherwise, in all the cases, now the recommendation say that CT
chest CT is required, sir.
Imaging investigations. Now, okay, this is the CT plate. It is very much obvious. Can you read the plate? Can you read the plate and say what are the findings?
Yes, sir.
Yes, sir.
Sir, so this is a contrast enhanced CECT of the abdomen and pelvis region, showing the liver. On the right side of the liver, there is heterogeneous lesion in the right lobe of the liver, probably 4 centimeter in size. And on the left side, there is a heterogeneous enhancing lesion up to 4 centimeter at the mid and lower at the mid pole of the mid pole of the kidney, sir.
And
opposite kidney is not. Yes, sir.
If you are not given the whole sequence of CT plates, kindly don't comment on the size of the lesion. Okay, if you are given all the plates, then only you can ascertain the size of the tumor, size of the lesion. So refrain from commenting on something that is not very much obvious from these CT plates. These CT plates, they may not be contiguous CT plates. These are just an indication. It is a heterogeneously enhancing renal mass in the left kidney along with central necrosis. Heterogeneously enhancing mass in the liver as well. So this is more or less the finding in this very plate. Sorry. Okay, so these are the CT findings. Now, CT chest is not available. The image of CT chest is not available here. Chest X-ray finding has already shown that there is a nodule in the right lung region. So now the diagnosis. What is the diagnosis? Final diagnosis at present.
Sir, this is a case of metastatic RCC.
Okay. Metastasis 2.
Metastasis 2. At this stage, liver is commentable, sir. Okay. Liver and lung.
Yes, X-ray, there is lung nodule. You can say pulmonary.
Yes, sir, liver and pulmonary and liver metastasis.
Okay. What other metastatic evaluation you would like to do?
So bone scans.
Sir, as the patient complain of bone pain, so bone scan can be done here. Patient does not have any neurological symptoms, so CT brain can be avoided. Hello. Hello.
I think, yes. I think Dr. Ashu is trying to reconnect. Let's wait.
Sorry, we were. 1 minute.
Anshuman, will you be able to share your screen, or shall we ask the organizers to share your slides?
My screen is. Am I audible?
Yes, but we can't see your screen. Please share your screen.
I'm sharing it. If it is not being visible,
We can see you. We can see you now.
Okay. So metastatic evaluation. Okay, bone scan. So let us discuss something about metastatic evaluation. CT MRI of abdomen and pelvis is needed, as already discussed. Chest radiograph and CT chest, the indications have been already discussed. Bone scan is indicated in this case. What are the indications for bone scan in a case of RCC?
Sir, raised level of alkaline phosphatase and bone pain. Patient complete new onset bone pain.
Can you do
Sorry, sir, you are not clearly audible.
When will you do CT brain?
Sir, patient when presenting with new onset
Hello?
neurological hello, sir. Patient presenting with patient presenting with some new onset neurological symptoms or epilepsy, something like that.
Okay, fine. And what are the indications? Is PET CT presently what the literature say, indicated or not, routinely recommended or not?
No, sir. Routinely, PET CT is not recommended, as the site of metastasis can be easily evaluated with the help of CT scan and the bone scan, sir.
Okay. What are the sites or metastases to which are more commonly the PET CT is for?
I think there are some connectivity problems. Ruma or Nirmal, could you please share Dr. Ashu's?
Okay, sir.
Anshuman, we are trying to share your screen from the organizer's side. You can just talk, because it seems your connectivity is poor, and maybe if you don't have to present the slides, it will be better. Just you can talk onto the slides.
I don't know.
Go on to slide number. Go on to slide number. I think he was on 10 or something. Yeah, carry on from this point. Are you with us, Anshuman? Hello. Anshuman, are you with us? Can you talk?
Yes, sir, I am.
Yeah,
I'm right now.
your slides are on the screen, and if you just ask Ruma, she will move them.
ଗୋଟେ କ୍ଲିୟର କରୁନାହାନ୍ତି ଗୋଟେ ପରେ ଗୋଟେ କଥା କହୁଛନ୍ତି ସେଟା କହିଲେ ଆପଣ ପୁଣି 22 ଦିନ ଯାଏ କହିଲେ ପୁଣି 22 ଦିନ ଲେଖିବାକୁ ଆପଣ କହୁଛନ୍ତି ମାର୍ଚ୍ଚ ମାସରେ କ୍ଲାସ
I my slides. Can you share again?
I have shared your screen. Hello.
It's not visible to me. I have stopped my video also. It has been next slide. Go to the metastatic evaluation slide. Next slide. Further. Yeah, okay. So we were discussing the indications which site for which site metastasis is. Hello.
Sir, actually you are not clearly audible, sir.
Hello.
Hello.
Discussing PET CT for which site is it very useful? That's what I was asking.
Sorry, sir, I could not get your question, sir. Its sound is cracking and
Dhansagar, we were talking, he let Dr. Anshuman come back on with a good connection. So he was presenting on metastatic evaluation. So you said you would not do a PET CT. Can you answer me why?
sir, because the site of metastasis of renal cell carcinoma, which has lung, brain, bone, which these are easily can be evaluated with the help of CT scan, sir. So PET CT as such for the metastatic evaluation is not recommended, sir.
Okay. So okay. So where were we? Next slide, please, Ruma. So in this particular patient, it seems a PET CT is done. Is there a result of this? Next slide, please. So what are you going to do next before you come to a treatment decision? So this is a man who has a renal mass, a liver mass, and a pulmonary metastasis.
Sir, this is a female patient with multiple metastasis to liver, bone, and chest. So we have to first risk stratify this patient to assess the performance status of the patient, and we'll go for and after the risk stratification, it comes in the IMDC poor, intermediate and poor risk category. So we'll as a standard of care, we'll start with the immune check inhibitor therapy and anti-VEGF therapy, sir.
There is one important investigation in this particular patient you should do before you take on her treatment. So what is that? So she's got a renal mass, a liver mass, and a pulmonary mass.
Sir, biopsy.
Sir, now?
Sir, renal mass biopsy.
Yes. Please take this on. I was just trying to get some time.
Okay, so
I have just asked Dhansagar actually that whether he comes to, before he comes to a treatment decision, what specific investigations he would do even after the CT scan, bone scan, and PET scan before he decides.
Okay, fine. Now I'll take over, sir, from there. So what is the plan of management here?
Sir, as PET CT had showed multiple site of metastasis in the liver, bone, and lung, we should proceed for the biopsy of the patient. Renal mass biopsy or liver mass biopsy can be done, sir, to assess the histology of the cancer and the metastatic site. And then we will categorize the patient according. We will risk stratify the patient according to IMDC criteria. This patient comes under the intermediate to poor risk category. So I will start this patient with the immune checkpoint inhibitor therapy along with anti-VEGF therapy, sir.
Okay. Before going to systemic therapy, fine, your answer is right. We are urologists, so we will be discussing more about the surgical aspect and not going. We will be discussing the systemic therapy also. So we will first start whether you will like to do a cytoreductive nephrectomy in this case or not.
So this patient has presented with hematuria, which is not intractable at this point, but there are some indications of cytoreductive nephrectomy such as intractable pain, intractable hematuria, presence of paraneoplastic syndrome, presence of hypercalcemia. Or we can do cytoreductive nephrectomy as in a clinic to categorize this patient as in a clinic for clinical trials before starting immune checkpoint inhibitor therapy. These are some indications where we can do for we can go for cytoreductive nephrectomy.
Okay, how do you define cytoreductive nephrectomy? What really is cytoreductive nephrectomy?
Pardon, sir?
How do you define cytoreductive nephrectomy? What is cytoreductive nephrectomy?
Sir, removal of kidney along with the Giroda's fascia.
Okay, and okay, fine. So a radical nephrectomy done in the setting of a metastatic renal SOL is called cytoreductive nephrectomy. Okay, so this is similar to the proper conventional radical nephrectomy or only. So if it is done in the setting of a metastatic disease, it is called cytoreductive nephrectomy. The indications you have quite well pointed out. These are the indications for cytoreductive nephrectomy. As next slide, please, Ruma. Next slide. Yes. Okay. So these are the EAU guideline recommendations that we have not to perform cytoreductive nephrectomy in poor risk patients. So the first thing you want to do before you go to the plan of management is to stratify the patient. Okay, risk stratify the patient. Now, what are the tools to risk stratify, or what? First, you tell me what are the prognostic factors when we are dealing with renal cell carcinoma, metastatic renal cell carcinoma. What are the prognostic factors? How can you classify these prognostic factors?
So the performance status of the patient. There are two risk stratification categories are there, sir, MSKCC and IMDC criteria. In MSKCC, there is a risk stratification is done with the help of 5 points. The performance status should be less than 80%. Absence of prior nephrectomy.
Fine. Those 5 points everybody knows, that is written in the books. Everybody knows, so don't need to go into the details. I was asking what are the other risk factors. These MSKCC and IMDC models have been given, and they have seen that these 5 or 6 points, they are more relevant. But what may be other risk factors? Do you know any other risk factors that are not part of these criteria? So that's what I was asking you. Can you classify the risk factors? No. So it has to be classified in 4 groups, mainly anatomical, histological, clinical, and molecular. Okay, all these are the risk factors, different risk factors. In anatomical, you have the tumor grade, size of the tumor, the extrarenal involvement is present or not, there are nodal metastasis or not. These are not present in IMDC or MSKCC criteria, but still they are the risk factors. So in histology, collecting duct carcinoma, medullary carcinoma, sarcomatoid or rhabdoid features, these are the poor risk factors. And clinically, you already said the performance status, presence or absence of cachexia, anemia, thrombocytosis, ESR, CRP, LDH, all these things are there. And in molecular, also the recent advances, they are giving carbonic anhydrase, 9-HIF, the hypoxia-inducible factor, PD-L1 expression, all these things are also the risk factors. So you have to know these risk factors also. So they have been grouped by MSKCC and IMDC criteria, and now we risk stratify the patient into favorable, intermediate, and poor risk group according to these criteria. Of these two, MSKCC and IMDC, which is more popularly used nowadays, and why?
IMDC risk criteria is used nowadays, sir, because
Why?
cytokine therapy, because it is based on the VEGF targeted therapy, sir.
Very good. Very good. So the MSKCC group, the patients were given cytokine therapy,
cytokines, and
therapy has been shown, has been superseded by the targeted therapy. So
yes,
more present day scenario, IMDC criteria are more important. So these were the points, the recommendations from the EAU about cytoreductive nephrectomy. You have already pointed out very well what are the different indications for cytoreductive nephrectomy. This is a flow. Next slide, please, Ruma. This is a flow chart where we can go for cytoreductive nephrectomy. We have to first assess the candidacy for this. The performance status, the patient is symptoms, having symptoms from the primary tumor, what are the extent of metastasis, and whether the primary tumor is resectable or not. If it is resectable and the candidate is good enough for cytoreductive nephrectomy, we can go ahead still with cytoreductive nephrectomy. Only thing is that we have to do complete resection of the tumor. You have to make the patient R0 resection. Then only it has some benefit, otherwise it has no benefit. So in cases where the metastatic diseases are not manageable by resection or otherwise, so in such cases also cytoreductive nephrectomy is not needed. And you rightly said about our case, that in our case it is a poor risk group case. So in that case, what happens that almost all the cases of poor risk groups, they need systemic therapy. And when systemic therapy is required, then cytoreductive nephrectomy should not be done first up. We have to start with systemic therapy and then go ahead with cytoreductive nephrectomy after response evaluation. And if the response is present, good response is present, and still the patient has good performance status, is a candidate for cytoreductive nephrectomy, and tumor is resectable, we can go ahead with that. Anyway, so coming to the local therapy for metastasis, next slide, please. So what previous slide, previous slide. Okay. what are the different options for metastatic sites? What we can do for the lung nodule?
For the lung nodule, sir, metastatectomy.
Suppose the patient had presented with a solitary pulmonary nodule. Not in this case, this is a different case, solitary pulmonary nodule. What are the options we can do?
Sir, we can go for metastatectomy of the nodule in the liver,
Yes.
in the lung lesions.
Yes, very good. Yes. So for liver,
if it is present in the one liver only, one part of the liver, then hepatectomy can be done, sir. Or there are other options.
yes.
Ablative
Okay,
therapy
fine.
has
Here the point is that liver metastasis usually portends to a poor prognostic criteria. Okay, the patient it is a bad prognosis in liver metastasis. So in such cases, systemic therapy is indicated. So metastasectomy is not the primary treatment that should be done. Okay, what are the treatment options for bone metastasis?
So bone metastasis, bone curettage can be done. Bone stereotactic radiotherapy can be done for local bone pain. Or we can,
Surgery and
if there is,
radiotherapy mainly are the mainstay of treatment in bones, and if the spine is involved, there is neurologic impairment, the neurological deficits are present, then we may go for spinal fixation and all those things. So what for brain metastasis? What is mainstay?
brain metastasis, yes, a symptomatic patient, brain metastasis, non-curative resection of the brain metastasis can be done. Or there is a role of
for brain radiotherapy is indicated. Anyway, next slide. So these are the EAU recommendations to control local symptoms. We have to offer ablative therapy, including metastasectomy, to patients with metastatic disease and favorable disease factors. Where there are not favorable disease factors, we have to go for systemic therapy. There is not much indication of metastasectomy in those cases, even if the tumor is resectable. Okay, that's the point I wanted to make. Anyway, next slide. Okay, now coming to your systemic therapies that you wanted to ask, you wanted to say anything before starting systemic therapy. What will you like to do?
So biopsy, I have already told, sir. Biopsy of the.
Okay. Now you have to tell biopsy. We don't have to do if the patient is a candidate for cytoreductive nephrectomy, and we are planning for a cytoreductive nephrectomy upfront. In such cases, biopsy need not be done. Even for the metastatic sites, it needs not to be done. It is only indicated when we are planning for systemic therapies. Why in systemic therapies biopsy is indicated?
To assess the histology and
what is the
histopathological type. So histopathological type of the RCC should be commented.
Why?
Because a clear cell RCC are more prone for more responsible for immune therapy rather than chemotherapy and
very good, very good. So most of the studies of systemic therapies have been done on clear cell RCC. Most of the data that we have are present for clear cell RCCs, and clear cell RCCs are the most responsive to these therapies. So if there is clear cell RCC, we have to go ahead with the plan of systemic therapy. If there are variant histologies, we have to modify things somehow with different drugs to be used in different scenarios. So next slide. So the indications of renal tumor biopsy in any case of RCC, if we are planning for an active surveillance of small renal mass, if we are planning for an ablative treatment, if there is metastatic renal mass and we are planning for systemic therapy, we have to do renal tumor biopsy. In systemic malignancy, where we are suspecting a secondary renal tumor, there we have to do the biopsy from here. And while doing biopsy, core needle biopsy is preferred over FNAC because it gives better results, better accuracy. Next slide, please. Okay, the previous slide, remain to the previous slide. So can you tell me the rationale behind the use of systemic therapy, immune therapy? why the thing has come, why the use of immune therapy has come in RCC. Chemotherapy has been found to be ineffective. Everybody
Sir,
knows
the
that.
tumor cells
How-
in the RCC has
Yes.
that energy dependent efflux mechanisms on their tumor cells. So their chemotherapy is not that much effective. Whereas it has been found that there is T cell infiltration in the tumor cell. So there is immunogenic response of the tumor cell. So the presence of PD1 and CTLA4 can be targeted, and the T cell downregulation which has been occurred in the tumor can be upregulated with the use of immunotherapy.
Okay, coming to the history of systemic therapy in metastatic RCC, did it start with PDL1 inhibitors or CTLA4
No.
inhibitors?
So it has been
with what drugs it started?
interleukin 2 and interferon alpha, sir. First of all.
So the rationale behind the use of immunotherapy, have you heard of something called abscopal effect?
No, sir.
No. Okay. Have you heard something of a spontaneous regression of metastatic sites in RCC?
Yes, sir. There has been evidence of 0.3 to 1% of spontaneous regression in RCC, which is the thing that there is a role of immunity in the management of.
This is the rationale. This was the rationale behind using immunotherapy in cases with RCC. It was shown that there were some cases where spontaneous regression would occur, and it was postulated that it is due to the immune mechanism of the body itself. The body itself has a defense mechanism to fight against the cancer cells, and this was seen to be effective with interferon alpha and IL-2 therapy, and also somewhat with allogenic stem cell transplantation. So this was the rationale behind immunotherapy, which has now gone further and further in research, and now immune checkpoint inhibitors and targeted therapies are used. So what drugs can you use? How can you classify those drugs that we are currently using? I am not going into the details of history of RCC management. Currently, what kind of drugs are we using?
Sir, we first risk stratify into the as per IMDC into good and good category.
You just enumerate the types of drugs. What are the different drugs, class of drugs that we are using?
Okay, sir. Combination of drugs is used as standard of care. Nivolumab plus cabozantinib, pembrolizumab plus axitinib.
You are not getting my question. I am asking broadly the classes of drug that we are using. I am not going into the combination.
Okay, sir.
Combinations are what are the different classes of drug we can use in metastatic RCC? And enumerate some of the drugs of that class.
Sir, immune checkpoint inhibitors first, which are targeting PD1, such as nivolumab and pembrolizumab. Then targeting for the CTLA4 are ipilimumab. Then VEGF antagonist like cabozantinib, axitinib, and lenvatinib.
Okay.
And tyrosine kinase inhibitors like sunitinib, pazopanib, and sorafenib can be used, sir.
Okay. And anything else? mTOR inhibitors?
Yes, sir. mTOR inhibitors like temsirolimus and everolimus.
There are different classes of drugs that are used presently. They are TKIs, the tyrosine kinase inhibitors of various receptor, VEGF receptor, PDGFR receptor, and all those things. So TKIs are main sunitinib, sorafenib, pazopanib, axitinib, cabozantinib. These are all the drugs, lenvatinib. These are all the drugs in that class. The second class is mTOR inhibitors, everolimus, temsirolimus. Okay. Third class is immune checkpoint inhibitors, wherein PD1 and PDL1 inhibitors in the form of nivolumab and pembrolizumab are there, and CTLA4 inhibitor, that is ipilimumab is there. So these are basically the different drugs. Now coming to the sequential therapy, how do you plan in this case? What drugs would you like to give in the first line?
Sir, in the first line, I would like to give one immune checkpoint inhibitor along with tyrosine kinase inhibitor or VEGF therapy, sir. In good risk category, sir. So nivolumab plus cabozantinib or pembrolizumab plus axitinib or pembrolizumab plus lenvatinib as a standard of care in good risk category. In poor risk category, same drugs can be used, but with the addition of nivolumab plus ipilimumab that is targeting the T cell only, PD-1 and CTLA-4. If these therapies has failed or patient cannot tolerate this therapy, the second line therapy or alternative therapy in these patients can be in the good risk category is tyrosine kinase inhibitors like sunitinib or pazopanib, or in the poor or intermediate risk category cabozantinib.
Very good. Very good. So the basic idea is that in first line therapy, we have to give a combination therapy of immune therapy along with tyrosine kinase inhibitor. This is the main thing in favorable risk. This combination is very well effective. In intermediate or poor risk groups, there may be that immune combination therapies may be required in the form of ipilimumab with nivolumab, as you rightly said. Now, the main constraints with such therapies in our setting, in our Indian settings, is the cost factor. These immune checkpoint inhibitors are very costly, around one cycle of treatment cost over lakhs of rupees. So this is not affordable to all the patients. So for such patients, as you rightly said, VEGFR inhibitors are still in the first line category. Sunitinib and pazopanib are very well used, and cabozantinib is kept for the poor risk group. It is more effective that way. Sir. And if on response evaluation we see that it is not responding, the treatment is failing, what are the second line management? How do you plan for second line management?
Sir, if the patient has received prior immunotherapy, so any VEGF therapy can be tried which has not been previously used,
very good,
along with any other drug of immunotherapy. Or if the patient has gone for prior tyrosine kinase inhibitor therapy, then we can go for nivolumab plus cabozantinib.
Very good. The basic idea is that the drug which we have not used so far, we have to use from some other class. That's why I ask you the classes of drugs that are to be used. So if from one class we have used a drug or a combination of two drugs, so we have to use something from the other class in the second line therapy. So that should be the basic idea. And I think with this, we can end our discussion here. Dr. Sarkar sir, if you or other teachers, if you want to ask anything more, I was disturbed a bit due to the connection issues. So
no, thank you very much. Actually, I think you finished right on time, and I think you made a very difficult subject, presented it very simply. And that applied to all. Everyone made. There were 4 very, very difficult cases, and I think all the discussions were very apt, and I think have brought out most of the important points which are discussed in exams and actually in practice in our day-to-day life. So I'm sure that all who attended have had a good experience. Now, I thought that I've got some MCQs which just as a concluding and summarizing session, and I thought that I would ask the organizers to share a little presentation, and let us try and summarize the things which have been discussed in today's meeting, yesterday and today's sessions, and some things which may not have been shared. One thing which was not shared, Samir, in your presentation on the advanced renal cancer, would you have any comment on the students about the role of angioembolization in the management of the large tumor that you showed?
Yes, sir. That is a valid point, sir. Actually,
yeah.
I missed it. That question should have been asked. Actually, there's a possibility shrinkage of size, though there are chances of complication of post-embolization syndrome, but still it's a valid point, and that should be one leading question.
Secondly, with this cable thrombus, the other thing which is quite frequently asked is the sequence of clamping and unclamping for a level 2 thrombus. Would you just elaborate on that for the students? Or at least they should read it up. You know, for a level 2 thrombus, I don't think they'll be asked too much about level 3 and level 4 thrombi. But the level 2 thrombus management is something which the surgical details are commonly asked in the exam.
Commonly asked, yes, sir.
Please ask them to answer. This is a very pertinent question. So one of them should answer how they clamp it.
Anyone can answer?
Yes, sir. The clamping should be done the infrarenal IVC first, then contrarenal renal vein, and then suprarenal IVC, sir.
Good.
And the declamping should be done in this sequence only, sir. Infrarenal IVC, then contralateral renal vein, and then suprarenal IVC.
What exactly you tell the anesthetist before clamping?
Before clamping, sir, I would ask anesthetist to check for cardiac output and mean arterial pressure, sir. If the patient can tolerate the clamping time, actually first we clamp and assess up to 2 to 5 minutes. If there is cardiac output, if there is a drop in the cardiac output more than 50% and mean arterial pressure falls down.
Ideally, you must tell the anesthetist to be prepared for any sort of hypertension. Usually there is a chances of hypertension. So you should inform the anesthetist. What extra precaution you will take if clamping or declamping sequence my question is to how to avoid the chances of dislodgement of any thrombus.
Yes, sir. Just before suturing,
before declamping, I am telling suturing is complete. Just before declamping, what extra precaution to be done to ensure the tumor thrombus is completely cleared?
So we allowed the 5 to 10 ml of blood to wash out from the side
below clamp to be taken out before suturing, so that gauge of blood to be out. One second point is to
positive pressure ventilation should be given before.
If the size of thrombus or the shape of thrombus is irregular or you are in a doubt, you can go for scopy. Third is placement of IVC filter. IVC filter can be used. That is one point that just to avoid any sort of dislodgement. Kalan sir, can anything else?
Yeah, Devango, hello.
Sir.
Sorry. Hello, Devango. Devango, we wanted to discuss a few things. That is, you discussed in your very first case about the small renal mass. This renal mass biopsy. What are the indications for renal mass biopsy? I think this has been discussed by many of the presenters. But how is the renal mass biopsy done these days? I think this is something which the students should know, and maybe or they can they answer any of them?
Anyone?
Yes, sir. Renal mass biopsy done by the TrueCut. At minimum 2 core is the minimum required, sir. And
before ablative therapy, it is indicated.
Core length is the 10 mm should be.
How it is done? How it is done?
It is done in the local anesthesia by the TrueCut needle with the help of the TrueCut needle.
Image guided?
Yes,
CT guided or USG guided, sir.
Either it can be done ultrasound guided or CT guided, but nowadays to be more accurate, CT guided is preferred. 2-core biopsy, TrueCut biopsy is done. FNAC is not advocated. We should do a TrueCut biopsy.
Hello. Am I audible?
Yes, sir.
Yes, sir.
Yeah.
Sir, I have one question, sir.
Yes.
Sir, if patient is the metastatic RCC with the IVC thrombus and patient is the poor risk patient, So how to manage this case?
You have to counsel the patient about the poor prognosis status and start with systemic therapy, start with targeted therapy in the form of checkpoint inhibitors in combination with VEGFR inhibitors or tyrosine kinase inhibitors. You have to start with that and look for any shrinkage of mass or anything, any response if there is. Usually such patients have very poor prognosis, and that has to be explained, and palliative therapy, the end care has to be given in most of the cases. So these are very difficult to treat and very difficult.
We can put IVC filter also.
We can go for an endovascular IVC filter,
yes,
along with systemic therapy.
Along with angioembolization.
How to you implant the IVC filter? If the thrombus is the completely occluded the lumen, what is the?
It can be done through upper arm. Here, the interventional radiologists do it.
Okay. So yeah. First we go to remove the thrombus, then go for the systemic therapy. The chances of the thrombus mobilization is the more in these cases. The patient might be the sudden death due to thrombus.
Yeah, but the thing is that these type of patients are not that much fit for surgery.
Yeah, I have seen one patient, sir. My patient has the metastatic RCC with the IVC thrombus. Patient performance score is the very good. Patient performance score is the 90. Equal performance is a 1. And patient is consulted for the surgery. And then
yes, some cases you can do it, but nowadays, according to the guidelines, if you have a IVC thrombus, then it's better to go for a TKI in metastatic scenario.
Okay, now let us just proceed to some self-assessment questions, and we can have a little discussion in the 10 minutes that we have. We truly have only 10 minutes. So renal biopsy, a generally accepted indication for renal mass biopsy is metastasis. I think so. If we are suspecting a metastasis to the kidney or a lymphoma, these are very important indications for a renal biopsy. And I thought that I would make that point for everyone's knowledge. And that basic way of doing a renal biopsy is that you pass the needle through it's a core needle biopsy or an FNSE with there is a access sheet through which you take a biopsy. And really it's done by the radiologists with CT or ultrasound guidance. And it has its own share of complications, but I think it's a very useful test. The other thing which today's discussion, I think many of the teachers and the students got out the importance of looking for renal function. So following a partial nephrectomy of a solitary kidney, what would be the most effective method of screening for hyperfiltration? Nephron.
B, sir. Albumin to creatinine.
Sorry?
B.
Albumin to creatinine ratio.
So what would you do if it's elevated?
Sir, we'll start with AC inhibitor therapy and low protein diet, sir.
Absolutely right. And you should, refer the patient to a nephrologist. And I think, in this preoperative counseling business for kidney tumor surgery, the nephrologist has a very big role. I'm going to miss this. I think I'll give you the answer. Cryoablation is not commonly performed, but it requires a double freeze-thaw cycle. And we've also discussed that MRI and CT are the best forms of imaging for cable thrombus. Now, this is important. In patients undergoing complete surgical excision of RCC, the lowest 5-year survival rate is associated with which factor? Perinephric fat, clear cell histology, IVC involvement, intra-atrial tumor thrombus, and lymph node involvement.
Lymph node involvement.
Lymph node involvement.
Very good answer. So, a patient has come with a small renal hilar mass, 3 centimeter. A core biopsy was done, and it's an oncocytoma. So, what are you going to do about it? He's 75, is otherwise fit. 3 centimeter centrally located mass. The other kidney is normal. Renal function is normal.
Observation. with follow-up.
Observation with follow-up imaging.
Absolutely right. Now, this sort of question, this sort of new knowledge about oncocytoma, this is something which makes us regret the numbers of kidneys which we old-timers have removed with large oncocytomas, knowing that they're benign disease. I don't know what the other examiners will say. If you've got there are times I think you also have all removed large kidney tumors, which then come back as oncocytomas. Ranjan, would you have any comment on this? Okay, we'll proceed.
Yes, sir.
Now, the other thing which I think is very important, and we'll just spend a little time on this, is the staging of RCC. The TNM staging was not actually discussed, but I think we all know that the 2016 TNM staging, TNM staging is fundamental to the diagnosis and treatment of renal cancers. At the end of your clinical, there's a clinical stage and a pathological stage. And at the end of the staging, we should be able to talk to another doctor and tell him that what is the TNM stage of the tumor. And in 2016, I think the last modifications, I think there are some, it's been simplified a bit. So the regional lymph nodes were N0 and N1. N0 means no node metastasis, N1 and metastasis in any regional lymph node, and N0 is no metastasis, and N1 is a distant metastasis. And it's the T1 to 2 criteria are important, but the T3 criteria shows a lot of changes. I think we should know that it is important to know that T3A is a tumor involving the perinephric tissues, but not beyond, Gerota's fascia. There is also the concept of renal sinus fat involvement, which apparently has a worse prognosis than this. So these are very, very important. I will tell all the students to go into the TNM staging, and I selected some from Campbell for this purpose. And with that, we'll finish today's session. So renal tumor 6 centimeters, pathology, venous involvement limited to main renal vein along with contralateral adrenal involvement with RCC. And a 6 centimeter bulky retroperitoneal lymph node replaced with cancer. So what is the stage?
T4 N2.
T3B N1 N1.
Sorry?
T4 N2, T4 N2.
T3A, is it main renal vein?
N1, M1, sir. M1.
Contralateral adrenal involvement is
Contralateral
M1.
adrenal involvement is there.
Yeah, so PT3A, N1, M1. So these are things because, if you look into survival data, these are important. So this, I think everyone knows that the most common mutation in sporadic clear cell is the inactivation of the VHL gene. And that, this I will miss out. I think it's important to realize that vena cava thrombi should be removed because they do not have that bad a prognosis. Can you tell me what is the 5-year cancer-free survival rate after a level 2 thrombus is removed?
Is it 30 to 50?
It is 71 to 90%.
30 to 50%.
Sir, B.
30 to 50%.
No, sir, B.
Actually, again,
31 to 50%.
It's 31 to
31 to
50%.
50%.
So I think the message is that, when you see a cable thrombus, it all is not lost and patients can survive. So again, some based on staging, according to the TNM staging 2016, which of the following tumors would not be considered stage PT3A? So D again, it's the 4.8 centimeter adrenal gland. So right. And there's another question. I think since obviously it makes supposed to make a difference, and when you look at this, then you think of the enthusiasts who do hilar partial nephrectomy, or when you address a hilar tumor, The prognosis
Oh.
for tumor invading the renal sinus fat is very poor.
The
Answer to this question- Sorry? Sorry? It is the answer, I think, is
Peripheral lateral movement থেকে ও renal sinus.
this is worse than a perinephric fat
Worse,
involvement.
yes,
It
D,
is
sir.
worse. Answer is D. Worse than a PTHPA tumor with involvement of the perinephric vein like this. So one should be very, you know, that this is recognized by all the scoring systems. The nephrometric scoring systems recognize that a centrally placed tumor are not only difficult to remove, but it's also a warning that they may be difficult to remove, but they're also dangerous. The single most important prognostic factor in RCC is? No, it is, well, it is B and C both. It's tumor stage and the and prognostication systems. So, and I think we are just running out of time. So I think which of the following indicates a tumor that is not correctly staged according to the 2016 system?
B.
Sorry?
Adrenal movement is CB.
B.
RCC with the other important point I'd like to make out is this RCC with the pelvic adhesion system involvement is PT3A. It makes the prognosis worse. So I think the choice should be between B and C.
B.
I think B is the wrong.
It is B.
Yeah. So that's it. RCC with direct ipsilateral.
Adrenal gland is 4.
So that's all really. That's all. I wanted to bring out the fact that the TNM staging is very important. And I think that that concludes our session. I will stop sharing now. How do I stop share? Stop share.
Yeah. Thank you, Dr. Sarkar, for an excellent session and so extensive. Even I was also sitting all the time, keeping myself mute to listen. I must thank Anshuman, I must thank Devanga for organizing the session so well. And I'll be very happy if the students express their views, how they have utilized their session, how they have felt that this session will help them.
And also how we can make it better. I think
better. That is the
the
intention. Make it better. What suggestion can we get from them so that we can make it better? Any of you who have part seriously, I really want to hear from you all. Nobody.
Yes, sir.
Vishal Kashyap.
Hello.
Hello, Vishal.
Yes, sir.
So, what do you think?
Yes, sir. It is a
What do you think?
Yes, sir. It is a very good conversation, sir. It is the very good.
First to introduce yourself.
Sir, myself, Dr. Vishal, sir, from the NRS Medical College, third year student, sir.
Okay.
Yeah.
So, how did you enjoy it?
Yes, sir. Yeah, I learned so many things from the faculty, sir, and so many doubts are cleared, sir, by the Anshuman sir and the Kalyan Sarkar sir and the Samir sir. And I taught so many things, new things.
Why I am asking this question, you may not know how much efforts are given by the teachers to make this session so much successful.
Yes.
So we'll be extremely happy if you utilize this and this comes to any help to any of you. Next week, we'll have another 2 very important sessions, that is penile cancer and the testicular cancer. Get prepared for it. Read it well in advance so that the efforts made by the teachers will be properly utilized by you.
Yes, sir.
Thank you once again,
Yes,
Samir, for your excellent effort. And we will be meeting soon in different examinations coming. So thank you, Kolanda. Thank you, everybody.
Thank you, Devango, Samir.
Thank you, sir.
Thank you, sir.
I think you all worked very hard.
Thank you. Thank you.
Thank you. Bye-bye.
Thank you.
Bye-bye. Thank you, Ranjan.
Back. Thank you.
Thank you.